with the understanding that these medications were not available until about 1950. Okay. And most of the advances in the development of these medications has been to reduce the side effects of both the antipsychotics and the antidepressants. So the newer medications have fewer side effects than the older medications. In some cases, they have different side effects, but they are, in general, less likely to cause these effects. They are less likely to cause... oh, can I have my pointer, my friends, my TA? Somehow I can't call it in on my own. Okay. Okay, thank you. Both antipsychotics and antidepressants can cause orthostatic hypotension because of alpha-adrenergic blockade. The anticholinergic effects we're very familiar with, the dry mouth, the urinary hesitancy, and also the central anticholinergic effect of confusion. And I mentioned yesterday the antihistamine effect of sedation and also of weight gain. And that's a severe problem. We talked about the fact that no matter what your weight, what your condition, let's say, most people are concerned about being overweight. At least in the US, that is the case. Okay. The antipsychotics also have neurological side effects. They have, and I mentioned the central anticholinergic effects, the extrapyramidal reactions, okay, which we also see. The extrapyramidal reactions involve low dopamine and our motor problems, Parkinsonian symptoms, and we talked about that when we talked about Parkinson's disease, which is treated with either drugs that increase dopamine or anticholinergics. Now, we would prefer to use benztropine, which is an anticholinergic drug, because anytime you increase dopamine in a person who has a psychotic illness, you risk of putting them into another psychotic episode, that is hallucinations and delusions. Okay, so anticholinergics seem to raise dopamine gently, very gently, and just a little bit. They don't push it way up, which can cause psychotic symptoms. Okay, my friends, how are we doing? How are we doing? Okay. Okay, good, great. Good to hear. Good. Wonderful, wonderful. Good to hear. Okay. So we're starting off this morning kind of with some heavy-duty stuff when we're talking about psychopharmacology. Okay. Okay, now, tardive dyskinesia is the most feared side effect of antipsychotic medications. Tardive dyskinesia is not caused by low dopamine like the other extrapyramidal side effects. Tardive dyskinesia is caused by supersensitivity of dopamine receptors after they have been blockaded for years with antipsychotics. So tardive dyskinesia rarely occurs before 3 to 6 months of taking an antipsychotic, and typically occurs after years. It's more common in older women than it is in any other group, and it occurs in quite a number of patients who are taking high-potency antipsychotics. Okay, so high-potency antipsychotics are drugs like haloperidol and fluphenazine. Okay. And tardive dyskinesia persists even after you stop the medication. Okay, so this is a situation where any amount of dopamine will set off these symptoms, which are also motor in nature. Okay. And some of the symptoms that we see in tardive dyskinesia are abnormal movements of the mouth and the tongue protrusion as well. And if you work in a situation in which you see a lot of older mental patients, and in our building at the medical school, we have as I told you, a day hospital for seriously ill people with schizophrenia who are older, we see this picture. because in the bad old days, before the atypical antipsychotics were developed, many patients would develop tardive dyskinesia. One of the biggest advantages of the newer medications, of the atypical new antipsychotics, is that they are much less likely to cause tardive dyskinesia, and they're also less likely to cause the other motor effects, like the Parkinsonian effects. So the older high-potency drugs are much more likely to cause these neurological disorders. Okay. So if we give somebody with tardive dyskinesia a drug to increase dopamine, and their dopamine receptors are already super sensitive, this is what can happen. Okay, so anti-Parkinson's drugs like anticholinergics, which we would use for the other motor symptoms of antipsychotic use, make this condition worse. Okay, as a matter of fact, this is one way we can differentiate between the Parkinsonian symptoms, which are motor symptoms, and tardive dyskinesia. That is, we give the patient an anticholinergic. If I give an anticholinergic to a patient with tardive dyskinesia, what will happen to these symptoms? Will they get better or worse if I give this patient an anticholinergic, my friends? Tell me. Yes, yes, of course, they will get worse. They will get worse. So sometimes, if we're not sure whether the symptoms are from tardive dyskinesia or are Parkinsonian, we give the patient a small dose of an anticholinergic medication. If the symptoms get better, we know we're dealing with Parkinson's symptoms. If they get worse, we may be, unfortunately, looking at tardive dyskinesia. Okay, so there is no treatment for tardive dyskinesia. We would switch the patient onto a newer antipsychotic that is less likely to cause these symptoms. But once the patient has tardive dyskinesia, they will have symptoms, most of them, for life. Okay, so this is why it's the most dreaded effect. The Parkinsonian symptoms are reversible with anticholinergics or by giving some dopamine, but tardive dyskinesia is not. Okay. Okay, my friends, how are we doing? Okay, good. Okay, okay, prevention. Sharina is asking, what about prevention of tardive dyskinesia? The only thing to prevent it is not to use the drugs that cause it. Okay, so we would try to start patients, and now we do not use high-potency antipsychotics except in emergency situations where we have an injectable form of haloperidol and the patient is dangerous to himself or others. We also use high-potency antipsychotics in patients who cannot maintain their medication and have to get an injection every few weeks rather than taking a pill every day. Okay, because many people with schizophrenia living in less than ideal situations where they may not have any privacy, they may not be able to keep their medications safe, and so those patients may elect to get an injection every 2 weeks, and that is called haloperidol decanoate. Decanoate is the long-acting form of haloperidol. Okay, so Haya is asking, are typical antipsychotics used only in those specific situations? That is, in an emergency situation or in a situation where the patient needs a slow-release formulation once every 2 weeks. There really is no role anymore for the low-potency antipsychotics. Let me just check back here. Okay, good. Okay, we're going to go forward. Okay, so here are, okay, so the non-neurological effects, the non-motor effects are cardiovascular side effects like orthostatic hypotension, Sexual side effects. Sexual side effects with antipsychotics have two causes. One is that you're lowering dopamine availability, and dopamine is the pro-sex neurotransmitter. The other thing is that under normal circumstances, and we talked about this when we talked about human sexuality, dopamine suppresses prolactin. So when you suppress dopamine, prolactin comes up, okay? And prolactin, as we saw when we talked about the subject, leads to sexual difficulty, difficulty with erection, menstrual irregularities, breast enlargement in males, and even galactorrhea, secretions from the breast. So sexual side effects caused by elevated prolactin are also a problem for patients. Okay, so in the days before the atypicals were developed, and this was more in the 1960s and 70s, we had only two choices for patients that were psychotic. We could use high-potency drugs like haloperidol and fluphenazine, I mentioned, or we could use low-potency drugs like chlorpromazine. The high-potency drugs were much more likely to cause the neurological or extrapyramidal symptoms, and the low-potency drugs would cause very few, would rather cause lots of anticholinergic symptoms. So all we could do in those days, if we had a patient who developed a lot of uncomfortable anticholinergic symptoms on chlorpromazine, we could switch them to haloperidol. And similarly, if they had neurological symptoms, we would switch them to chlorpromazine. So here are the two that are still used. There are others that are also used. Pimozide is another one. Remember Pimozide? Okay. It's used to treat what? What is Pimozide used to treat? Pimozide. Haloperidol is indicated, and so is Pimozide for what condition, my friends? Let's see if we're all alert. What do we use Pimozide for? Okay, we have a couple of people typing. Let's see if you got it. Okay. Okay. Okay, the Pimozide and haloperidol are indicated in the treatment of Tourette syndrome. Remember Tourette syndrome? High-potency antipsychotics are used. Okay. Okay, so we still do use the high-potency antipsychotics, but there's very little reason to use the low-potency drugs anymore. So those both high and low-potency drugs are typical antipsychotics. They are dopamine 2 antagonists, and they are primarily helpful for the positive symptoms, hallucinations and delusions. But they have a lot more side effects, both neurological side effects and non-neurological side effects. The newer group of antipsychotics are called the atypical antipsychotics, and we'll talk about them quite a bit. They block dopamine 2 receptors. They also block dopamine 1 and dopamine 4 receptors. Okay. They also are more useful for treating the negative as well as the positive symptoms of schizophrenia. And the side effect profile is better. Nevertheless, atypical antipsychotics do have side effects, and one of the most disturbing side effects is their tendency to cause excessive weight gain, which is so excessive that it leads to diabetes mellitus. Okay, so patients on atypical antipsychotics can gain 20 or 30 pounds within a few months, okay, leading to other metabolic problems. Okay. Okay, so we'll be taking a look at which ones are worse and which are better among the atypicals in just a little while. Now, clozapine was the first atypical antipsychotic. And clozapine is the most powerful antipsychotic for negative symptoms of schizophrenia. Okay, so clozapine is really the star among the antipsychotics. It will help a patient's functioning better than any of the others. However, and clozapine works not only on dopamine 1 and dopamine 4 receptors in addition to dopamine 2, but also works on serotonin receptors. Okay, so it has a strong effect of blocking serotonin receptors, and that seems to be part of its action on negative symptoms. The problem, of course, with clozapine is that it has a significant side effect profile, and the side effects that it causes are life-threatening. For example, agranulocytosis, very, very low white blood cell count, and seizures. So whenever you have a patient and you would like to use clozapine, you have to ensure that the patient is compliant and will come back for regular blood tests. What is the presentation of a granulocytosis in the emergency room? You have a patient with a very, very severe infection. That's right. Absolutely, Shireen. Absolutely. And particularly a throat infection. And the patient's immune system is essentially gone. So the throat infection is life-threatening. Okay. And Faisal is asking, is it recurrent? Well, the infection will occur when the immune system is down. Okay, so if the immune system is down, infection will occur. Okay. Okay, but clozapine is not associated with extrapyramidal symptoms. That is, it's not associated with motor symptoms. So that's an advantage over the older drugs. It doesn't have effects on prolactin, nor does it have sexual side effects. But clozapine is the worst of all in causing the weight gain, the diabetes, and also sedation. So it has very good effects in patients who can tolerate it without too much sedation or weight gain. Okay, we'll see clozapine again. Risperidone was developed after clozapine. It is the most commonly used atypical antipsychotic. It does not cause agranulocytosis. It is useful somewhat for the negative symptoms as well as the positive symptoms. It has a number of side effects, anticholinergic side effects, antihistaminergic side effects, and does elevate prolactin a bit and can cause extrapyramidal symptoms like tardive dyskinesia and Parkinsonian symptoms. So of all of the atypical antipsychotics, risperidone is the one most likely to cause these symptoms, the extrapyramidal and prolactin elevation. Olanzapine also causes weight gain and diabetes. It is, has a relatively low rate of side effects. It's a popular drug among many psychiatrists, and it is helpful for the negative symptoms. But of course, clozapine is, remember, the star. Okay. A patient with schizophrenia had been withdrawn for over 10 years, but since being put on a new medication, he's more outgoing and sociable. The new medication is most likely to be, and we have a list of medications, my friends, so I'd like you to use your clickers on this and click in your responses. Okay, we're running down to the last second here. Very nice. 2/3 of you got it right. The answer is our star, clozapine. Okay, remember that clozapine is most effective for the negative symptoms. And what this patient is showing are negative symptoms. Withdrawal and apathy are negative symptoms. They're things that the person has lost. They have lost their sociability and their outgoingness. And now he's showing his outgoing nature and he's being sociable and more friendly. So he's been taking clozapine. Okay, my friends, how are we with that? Okay? Okay. Now here's a table that is describing the adverse effects of the atypical antipsychotics. And here it says older atypicals because there are a group of new atypicals which are not on this chart. Okay? So here we have the typical atypicals, and here on this little list I have the 4 new atypical antipsychotics that have all been approved by the FDA. Paliperidone, acenapine, iloperidone, and lurasidone. Okay, so we'll get to those in just a minute. Let's take a look at the standard atypical antipsychotics, and their adverse effects are in the left column. So weight gain and diabetes, which is a very significant side effect of the atypical antipsychotics. You can see that clozapine causes the most. Olanzapine is right there next in line with causing weight gain. But aripiprazole and ziprasidone do not cause weight gain and diabetes, or cause, let us say, or remember that all antipsychotics can cause all of the side effects. These are much less likely, these two, the A and the Z, to cause weight gain and diabetes. Increased QT interval and other cardiovascular effects are more common with ziprasidone. So ziprasidone is a drug that we avoid in patients who have cardiovascular disease already. Okay. Sedation. Remember that in psychiatric patients we don't want sedation. We want them to be able to function. Nevertheless, clozapine, olanzapine, and quetiapine all cause significant sedation. Okay. And an advantage of risperidone here is that it doesn't cause much sedation at all. Extrapyramidal symptoms and prolactin elevation, which is the one, my friends, that causes extrapyramidal symptoms and prolactin elevation. Which is the antipsychotic that's likely to cause those? Okay. Yes, that's right, the one most commonly used, risperidone. The trade name of that drug, and that's why some of you have sort of a mixed bag name for the drug. The trade name of this drug is Risperdal, okay? But the generic, of course, is the one we need to know, and that is risperidone. So risperidone, among all the antipsychotics, among the atypicals rather, is most likely to cause extrapyramidal symptoms. Okay. So what I can do with this table, if you like, is I can put it up at the break if you remind me, or my TA reminds me, okay? Because I just move on and on. Okay, so let me know if you want to see this table again, and I will put it up at the break. Okay, so paliperidone is made by the same company that makes risperidone. The advantage of paliperidone is that it's metabolized by the kidney rather than the liver. So in patients with liver disease, this can be significant and a good choice for them. Acenapine, another new atypical antipsychotic, is available in an under-the-tongue formulation. It can cause some extrapyramidal symptoms and sedation. Iloperidone is a drug like ziprasidone, increases the QT interval, but has very little effect on causing extrapyramidal symptoms. And lurasidone, which is the one that we've seen already on the boards, can cause some extrapyramidal symptoms, but it is in pregnancy category B, which is and I'll talk about the pregnancy categories in a little while. Pregnancy category B is no studies in humans have shown any danger to human fetuses, and most of the psychoactive drugs are in category C, okay, which is a worse category with respect to effects on the fetus, okay. But we'll be looking at the drugs and their categories at the end of this section, okay, my friends. So those are the antipsychotic medications that are currently available in the U.S. Our next group of medications are the antidepressants. And we have talked about the antidepressants under so many different categories, that they're used to treat depression, and they're used to treat bedwetting. Remember the old antidepressants used for bedwetting. They're used to treat the anxiety disorders. And they seem to be useful for chronic pain. Even if the patient is not depressed, they seem to affect pain pathways. Okay. So chronic pain with or without depression. I thought you might like this cartoon from the New Yorker magazine. Of course you feel great, one of them says to the other. These things are loaded with antidepressants. These things being us, people. Okay. Okay. So all you have to do in the United States, or probably in many places in the world, is eat a few people and you'll get your dose of antidepressant for the day, because many, many Americans are taking these drugs. We'll look at the numbers in just a minute. Okay, so the antidepressants come in 3 basic classes, and then there are others that don't fit into these categories. Okay, my friends, I see that I have my catatonic features have returned. So if you'll just give me a moment, I'm going to check out and check back in again. Okay, so just a moment. Okay, there I am moving again. Okay. Thank you, Miriam, for telling me about the webcam, because I wasn't watching the webcam. Thank you. Okay. Now, Hinge is asking about, oh, I have catatonic features. Yes, I did have catatonic features. That's a good way to remember it. Just remember Dr. Fatum's frozen webcam, and you'll remember what catatonia looks like. Okay, very good. Okay, so these are the groups of the antidepressants. The cyclic antidepressants, which are both serotonin and norepinephrine reuptake inhibitors. The SSRIs and the SNRIs. Okay, the SNRIs were developed from the SSRIs. Okay. And they are selective serotonin and norepinephrine reuptake inhibitors, and they have very few side effects. That is, they are less likely to affect the cholinergic receptors and histamine receptors. They just work on reuptake of serotonin and norepinephrine. The cyclic antidepressants work on block reuptake also, but they also have more effects on other receptors, more side effects. Okay, so SSRIs and SNRIs are the drugs most commonly used now. And the most common drugs, of course, are the SSRIs. And the reason is because their side effect profile is excellent. They do, though, tend to cause sexual side effects even more than the traditional agents. The monoamine oxidase inhibitors, and we've talked about them already, block the breakdown of the monoamines. Okay. And therefore serotonin and norepinephrine persist in the synapse. If they are not broken down by monoamine oxidase, there will be more of them in brain synapses. And the idea is to get your level of serotonin, norepinephrine, and dopamine increased in the synapses of the brain. And that happens really very quickly, no matter which of the antidepressants you use. But it takes about 3 weeks for all antidepressants to work. So it is believed that what has to happen is that postsynaptic receptors have to be altered, and that process takes 3 weeks to happen. It's not just raising levels of neurotransmitter in the synapse. You also have to let those raised levels alter the postsynaptic receptor profile. Okay. And we'll be talking also about some others that don't fit into any of these 3 groups. This is the antidepressant use in the United States. Exceeds 10% of the population. That's a huge number of people. Nearly 11% of Americans are on an antidepressant, with those age 40 to 59 taking more than any other group. And particularly, this is females. This is the 40 to 59-year-old age group, this green bar. And between 20 and 25% of women in this age group are taking an antidepressant. Are all of these patients depressed? Or are antidepressants being overused? And that's a question we have not answered. Okay. They seem to be helpful in patients who have a lot of anxiety, though, as well as depression. They are relatively side effect free, the newer drugs. So it's relatively easy to try them on a patient to see if it helps their emotional problems. And of course, the drugs are also used for anxiety and also for chronic pain. Okay. Okay, so the cyclic antidepressants have quite a number of adverse effects. They have significant anticholinergic effects because they're not clean for the serotonin and norepinephrine. They have central nervous system effects. They have cardiovascular effects. They tend to increase the QT interval and cause orthostatic hypotension. So we avoid cyclic antidepressants in patients with coronary diseases, okay, because of their cardiovascular effects. Okay, now here is a pill that's very famous in the United States. You can see the name of it. Some people call it vitamin P because everybody's taking it. Okay, not everybody, but many people. It is this whole group, and Prozac, of course, was the first of the atypical antidepressants, the SSRIs. They are the most widely used, all of them. Their side effect profiles are so similar that the boards will not ask you to distinguish among them, okay? And they're used for anxiety disorders as well, okay? Their primary adverse effects are sexual side effects. And here we have 15% of patients, the number may be even higher, okay? So sexual side effects are very, very common with the atypical antipsychotics. And one of the uses of them, you will remember, is for patients who have premature ejaculation. This delayed orgasm side effect is very helpful. And so the SSRIs are used in patients who have premature ejaculation as well. Now, one thing we have to be very careful about is elevating serotonin too much, because very high levels of serotonin lead to a life-threatening condition called the serotonin syndrome. So one thing we don't do is we don't use monoamine oxidase inhibitors and SSRIs, because both of them tend to raise serotonin. We also have to avoid medications, other medications that raise serotonin, and some of the pain medications do that, okay? So there are certain medications that have to be avoided when a patient is taking an antidepressant, particularly an SSRI, okay? Here are the SSRIs, okay, that are currently available. And as you can see, they have somewhat different side effect profiles. But in general, they have almost no side effects. And one of the things a patient will say to you is, "What are you giving me, doc? This stuff is a sugar pill," because they'll be taking it for weeks without any side effects or any effects on their depression either. Okay, so this is something that is up to the doctor to develop trust in the patient, to reassure the patient that these drugs always take a long time to work, and to keep taking their medication. So sometimes a little bit of side effect is not a bad thing, because at least the patient knows you're giving them something. Okay, but these drugs, many of them really don't cause any side effects. The only side effects we do sometimes see early in treatment are GI side effects. They cause some nausea in some patients. And fluoxetine in particular can cause a little bit of weight loss early in treatment. And depressed people also, when they're not depressed, will be concerned about their weight. Okay, when people are very depressed, they don't have an appetite, and they've typically lost a significant amount of weight. Okay. Let's take a look at this question. A 40-year-old man comes to the emergency room with a 4-day history of vomiting and diarrhea. The patient has elevated blood pressure and body temperature, as well as myoclonus. Aside from a slightly elevated white blood count, okay, blood and urine tests are within normal limits, and there's no evidence of infection. The patient, who has been on 40 milligrams a day of fluoxetine. Now, 40 milligrams a day is a dose that many patients take, but it is a bit higher than the one that most people take. Most people take 20 milligrams of fluoxetine a day to maintain their mood status for the year that they're taking the drug. Remember, we maintain the patient on the drug for a year. He's been taking it for years, which means he has had recurrences of depression, and now he's on it chronically, on fluoxetine. He's recently started to take a new medication for back pain. Which of the following pain medications is most likely to have been prescribed for this patient? So here we have a picture, a group of symptoms which can be life-threatening, indicating that this patient has serotonin syndrome. Okay, so he has taken, obviously, a medication, and since this just started 4 days ago, it's related to his new medication. What has he started to take? Okay, my friends, we have, and you can put the timer on now, oxycodone, hydrocodone, gabapentin, tramadol, and ibuprofen. You may or may not know this, but you will know it by the time we finish talking about this. Okay, click in your answers, my friends. See how you're doing here? This is a hard question because unless you know which of these medications elevates serotonin, you're not going to be able to answer this question, right? And oxycodone and hydrocodone do not work through the serotonergic system. They work through the opioid system and dopamine. Gabapentin is a GABA agonist, okay? Ibuprofen does not have specific effects on neurotransmitters. The answer is tramadol. Tramadol, and the trade name of this drug in the U.S. is Ultram. Ultram, T-R-A-M at the end. Tramadol is a drug that works on pain by increasing serotonin. Okay. So we have to avoid tramadol, and another drug, which we'll see in a little while, that elevates serotonin is meperidine. Meperidine, and we'll see the spelling of that. It's M-E-P-E-R-I-D-I-N-E, and we'll see it in just a minute. So we have to avoid tramadol and meperidine when patients are taking drugs that increase serotonin, like SSRIs. Okay. Now here are two newer agents, which are the SNRIs, Okay. Um, the SNRIs, two that are currently approved for depression, are venlafaxine and duloxetine. These drugs inhibit reuptake selectively, okay, of norepinephrine and serotonin. They work, and you may remember this, they work about 1 week faster than the SSRIs, and they are as effective as the SSRIs. They also are less likely to cause sexual side effects, okay, but they are more likely to cause problems with blood pressure and GI problems. So the elevation of blood pressure, although it is not large, can be problematic for some patients, okay, who already have hypertension. Okay, the SSRIs do not affect blood pressure. Okay, and that's a significant advantage, particularly for the elderly. Duloxetine is also indicated for depression, but it also has an indication for fibromyalgia. What is fibromyalgia? And I think you're going to answer it the same way that I would answer it. That is, nobody really knows what that is. We do know that the patient has pain, which is unexplained by pathology. There's nothing specific in laboratory tests in patients with fibromyalgia. Nevertheless, they are quite impaired by pain. And duloxetine has been approved by the FDA to treat those patients. So unexplained pain seems to respond to some of the SSRIs and SNRIs. We also use the SSRIs for chronic pain syndromes. So serotonin is helpful for pain, although the mechanism is not completely clear. Okay. By the way, the boards has never had the word fibromyalgia on it. Fibromyalgia, chronic fatigue syndrome are syndromes that we have no real explanation for. So the question of whether they should be in the somatic symptom disorders, that's pretty much been ruled out. They are not specifically in the somatic symptom disorders. There may be psychological bases to some extent. There may be pathology that we just cannot yet identify. In any case, these medications do work for fibromyalgia, and particularly the SNRIs. So SSRIs are also used, and SNRIs. Okay, let's take a look at this question. A 26-year-old man comes to the emergency room with elevated blood pressure, sweating, headache, and vomiting. His companion tells the doctor that the patient became ill at a party where he ate pizza and drank punch. Punch is a fruit juice that is laced with alcohol, typically, and it comes in a great big bowl with a ladle, and people spoon it into their cups and drink it. So what this is showing us is that sometimes patients who have food restrictions go someplace to a party or to a restaurant and don't realize that the forbidden food is in what they're eating, okay? And they have problems because of that. Okay, so what has happened to this patient is his blood pressure is so elevated that it could, in fact, shorten his life. Okay. So what drug is he taking? Fluoxetine, lithium, you can start the counter, nortriptyline, phenelzine, or haloperidol. What drug is this man taking? Okay, my friends. You have to think way back for this drug. Okay. Which is the one drug on this list that is associated with food restrictions? Okay. And the answer is, my friends, this one, right? Okay, no, fluoxetine has no food restrictions. Fluoxetine and the other SSRIs can be taken any time of day with any kind of food. There is no food restriction, which is why they're so useful. We haven't talked yet about lithium, which also does not have food restrictions. Nortriptyline is a cyclic antidepressant. There are no food restrictions. Remember phenelzine, my friends. Remember phenelzine. Phenelzine is what kind of a drug? It is an antidepressant. What kind of a drug is phenelzine? What's the problem here? Okay, I see some of you are typing. That's right, it is a monoamine oxidase inhibitor. Now, what has happened to this man is that he's taking an antidepressant, a monoamine oxidase inhibitor, phenelzine, which is the only MAOI on this list, okay? And he's taking this MAOI, and it's supposed to block the breakdown of monoamines in his brain so that serotonin, norepinephrine persist in his brain synapses. But it's also blocking the breakdown of neurotransmitters in the gut, okay? So he has eaten a food that contains tyramine. Tyramine is a pressor, and tyramine is also broken down by monoamine oxidase. So you're giving this patient a drug that stops the breakdown of tyramine, okay? Therefore, tyramine will persist, and tyramine will increase his blood pressure. Right, it's a tyramine reaction. This is also commonly called the cheese reaction because aged cheese causes it. It's also called a hypertensive crisis because it is a hypertensive crisis. Here are the currently available MAO inhibitors, and for the boards, you do need to know the names of the drug and which class they fit into. So if you see isocarboxacid, you need to know that that is an MAO inhibitor. Tranylcypromine also, and selegiline. Although in your notes it says selegiline is not used for depression, it is now used for depression, and it comes in a skin patch formulation that is put on the skin with a gradual release and avoids the GI tract. Okay, so selegiline in a skin patch formulation is now used for depression. Okay. So here are some of the foods. Aged foods, sauerkraut, which is aged cabbage, sausages, chocolate. Most of us would feel pretty badly about that. Avocados, and also patients have to avoid red wine, which may have been in the fruit punch that he was drinking. So the aged cheese was probably on the pizza that he ate. He may not have realized that aged cheese was on it. Certainly there is mozzarella cheese, which is not an aged cheese on pizza, but other cheeses like Parmesan and Romano have to be avoided. And those are also on pizza sometimes. Okay. So the patient has to avoid tyramine. There are other foods as well on this list. Bananas is another one that is to be avoided. So there are lots of restrictions, which is why when you put a patient on an MAO inhibitor, you have to have a patient who is adherent and compliant and who understands the instructions well about diet and also about avoiding drugs that increase norepinephrine. Okay, because norepinephrine cannot be broken down, okay, because you're giving the patient a drug that's preventing the breakdown of norepinephrine. You want norepinephrine in the brain, but what happens is norepinephrine levels get too high, okay, so whether they're eating a problem food or wine, or they're taking an amphetamine, norepinephrine levels get high, and that leads to the hypertensive crisis. Okay. So the patient has to avoid over-the-counter allergy medications like pseudoephedrine, dextromethorphan. Okay, also. And also the patient has to avoid drugs that are highly serotonergic because serotonin is not being broken down in the brain either. So you can also see the serotonin syndrome in patients taking MAO inhibitors. Okay, so we also, with MAO inhibitors, have to avoid meperidone and tramadol, the two serotonergic pain medications. Okay. Okay, and here is what the hypertensive crisis looks like. And this is caused by elevated levels of norepinephrine. So the greatly elevated blood pressure, occipital headache, stiff neck, nausea and vomiting, chest pain, dilated pupils, and nosebleed. And this is a life-threatening situation. So this is elevated levels of norepinephrine, elevating blood pressure, caused by certain foods and certain medications. Okay. Let's look at this question. A patient taking fluoxetine, what's fluoxetine? An SSRI, right? Lithium, which we haven't talked about yet, and we will. And flufenazine. Flufenazine, you remember, is a high-potency antipsychotic. Has a temperature, so the patient's taking an antidepressant and an antipsychotic, which is not at all uncommon, okay? We try not to use these drugs together because they can cause severe problems, okay? The patient has a temperature of 104, that's very high, blood pressure high, and intense muscular rigidity. He's very, very stiff. Okay. Lithium levels are within the normal range. So they're basically telling you, take lithium out of the picture. This clinical picture is most likely due to, okay, we have 1, 2, 3, which would be A, B, C. And you can start the timer. Good, I think it's already been started. Okay. Okay, and we have a couple of questions here. Haya selegiline is a monoamine oxidase A is the most important receptor with respect to depression. Okay. Selegiline is used in Parkinson's disease so that dopamine persists in brain synapses. Okay, that's why it's used in Parkinson's. That is, dopamine is not broken down by monoamine oxidase inhibitors. Okay, so it is used in Parkinson's. Okay. Ibrahim is asking me why no amphetamines. Amphetamines elevate norepinephrine, and so do the monoamine oxidase inhibitors. So that would be a norepinephrine reaction, which is what we see when we see that greatly elevated blood pressure. Okay. So here the question is this fluoxetine or is it flufenazine? And the answer is that this is a side effect of antipsychotics called neuroleptic malignant syndrome, which is a life-threatening side effect of antipsychotics. Okay, this is not the serotonin syndrome, and this is why, because of this intense muscular rigidity. Okay, there would also be here lab findings. Okay, lab findings, because when we have a patient who has neuroleptic malignant syndrome, in contrast to serotonin syndrome, neuroleptic malignant syndrome has lab findings. Okay. And this table is my table. Okay. This is a comparison of the 3 life-threatening syndromes that you can see with psychoactive medication. Okay. The first is neuroleptic malignant syndrome. Okay. Which is caused by dopamine blockade. Okay. I'm just going to make a note about the table. I think that the Dopamine blockade should go first. Okay. First. Okay. Okay, so neuroleptic malignant syndrome is caused by antipsychotic medications. It's caused by blockade of dopamine, which leads to many of the side effects of the antipsychotics, and this is just another one caused by dopamine blockade. It's characterized by autonomic instability. Sometimes the blood pressure is very high, sometimes it's very low, pulse rate is very variable, fever, confusion, mental status changes, that is delirium, lead pipe rigidity. Remember, we saw in that patient, the patient was totally stiff, like a Parkinsonian patient. Okay. Very slowed movements, like a Parkinsonian patient as well. So these are extreme symptoms which resemble the Parkinsonian symptoms, but also include life-threatening autonomic instability and fever. Okay. Lab findings, elevated CPK and liver enzymes will be found in patients with neuroleptic malignant syndrome. And the management is to stop the agent, to give a muscle relaxant like dantrolene, which we also use in patients taking antipsychotics with the stiffness side effect, and a drug which will increase dopamine, a dopamine agonist such as bromocriptine. Okay, so neuroleptic malignant syndrome caused by antipsychotics that overblock dopamine receptors. Okay? Serotonin syndrome is associated with the use of SSRIs and or MAOIs, along with other medications that raise serotonin, like meperidine and tramadol, the two pain medications. And you can see that the symptoms are very similar. That is autonomic instability, similar to neuroleptic malignant syndrome, fever, mental status changes, confusion. But here we're more likely to see muscle spasms rather than stiffness. So we see myoclonus, increased activity, hyperkinesia, and a more rapid onset, and no lab findings. Okay, no lab findings. This is caused by excess serotonin. We stop the agent, and sometimes we can use this anti-serotonergic medication, cyproheptadine. Okay. The third syndrome, the life-threatening syndrome caused by psychoactive medications, is a hypertensive crisis, which is related to excess norepinephrine, caused by using monoamine oxidase inhibitors, plus tyramine, which is in various foods, okay, or monoamine oxidase inhibitors, plus drugs that contain norepinephrine-like substances, okay, like Sudafed, like over-the-counter antihistamines, okay. Okay. Now you just let me know which tables you want. I guess you will let your TAs know at the break which, we are on the break, okay, so that's a good spot to leave this up. Okay, we're going to leave this table up during the break. And if any of you want to see the other table about the atypical antipsychotics, we can certainly put that back on at your request. It's time now for our first 10-minute break. See you in 10 minutes. Okay, welcome back. I hope you've gotten anything you need out of this table. Okay. Basically, we're talking about the 3 life-threatening syndromes caused by psychoactive medication. Dopamine blockade causes NMS. Serotonin excess causes the serotonin syndrome. And norepinephrine excess, the hypertensive crisis, which we see particularly when patients take monoamine oxidase inhibitors and eat foods containing tyramine or medications that elevate norepinephrine. Okay. Okay, so the only treatment for the hypertensive crisis is to lower the blood pressure with medication and to stop the MAO inhibitor. That's true for all of these life-threatening syndromes. Other drugs that we want to specifically highlight because they have been on the boards frequently. Trazodone is a cyclic antidepressant, which is highly sedating. This sedating property is useful for some patients, particularly patients who need sleep medication but have a history of substance abuse. So we don't want to use GABA agonists in those patients. We would like to use antidepressants, and because of the sedating nature of trazodone, it's useful for sleep problems in patients, particularly those who, as I said, have a history of substance abuse. Trazodone, though, can also lead to persistent erection, a priapism, which, as I mentioned and as you know, is a medical emergency. Okay, this is one of the drugs that is other drugs, okay. Bupropion is, the trade name of this drug is Wellbutrin, and it also has another trade name because the drug company was able to get another indication for bupropion. Does anybody know what Zyban is indicated for? Okay. Does anybody know what Zyban is indicated for, my friends? Well, I don't see any responses yet. What is the answer? Okay. Okay. Zyban is indicated for smoking cessation. Wellbutrin is the name of the exact same drug when it's indicated for depression, and Zyban is the trade name when it's indicated for smoking cessation. Now, the reason that it's useful for smoking cessation is that it acts like a stimulant. Okay, so the effect of bupropion on depression is to act as a stimulant. Okay. Okay, so it is an inhibitor of dopamine reuptake, very much like some of the other stimulants we looked at. No effect on serotonin at all. So it has no negative sexual side effects, which makes it particularly useful for patients who have sexual side effects when they use SSRIs. It is not sedating. Again, it acts more like a stimulant. The side effects are like stimulant side effects, appetite suppression and insomnia. So it elevates dopamine, okay? Therefore, in patients who have seizures, that is, patients who have a lowered seizure threshold, such as patients with eating disorders like bulimia, cannot take bupropion because it can induce seizures. Drugs that can inhibit, or rather that increase dopamine, have the potential to cause seizures. Okay, so bupropion is one of them. Okay, let's take a look at this question. Which of the following medications is most likely to cause sinus tachycardia, flattened T waves, prolonged QT interval, and depressed ST segments? So we can start the counter. We have some SSRIs here. Fluoxetine, sertraline, and citalopram are SSRIs. We have bupropion, and we have imipramine. Okay, my friends, how are we doing on this one? I think our time is up. Okay. Here's our arrow. Let's see where the arrow goes. Where's the arrow going to stop? It's going to stop right here at imipramine. And 77% of you got that one right. Good. Because imipramine is a cyclic antidepressant. And we have to avoid cyclic antidepressants in patients with cardiovascular problems because it's likely to cause these side effects. Okay? So the answer is imipramine, which is the cyclic antidepressant. Okay, now there is another option. If a patient has not responded to 3 different antidepressants and they're still depressed, electroconvulsive therapy is an option. But electroconvulsive therapy has a very bad name in the United States. That is, people don't like the whole idea of it. And it is a little bit creepy when you think about it. That is, an individual has a seizure induced, and then after the seizure, their depression lifts. How does electroconvulsive therapy work? We don't know. We do know that no matter what causes the seizure, whether it's a high fever or too much insulin, patients with depression will show improvement after a seizure. Okay. That had been observed, that improvement after seizures had been observed way prior to 1950, and seizure therapies were used even back in the 1930s. Okay. Later on, seizure therapy used to be induced, as I said, often by insulin, which is dangerous. The patient's blood sugar can get so low that they die, okay, not just have a seizure. This is a safe and effective treatment. That is to use electricity to induce the seizure. As I said, the treatment has a bad name because of movies like this, and some of you may know about this movie, One Flew Over the Cuckoo's Nest, where Jack Nicholson plays a criminal, common criminal, who makes believe he malingers mental illness so that he will be put in a psychiatric hospital rather than in a prison. He probably would have been better off in prison because the psychiatric hospital was what we call a snake pit. It was a torture place, torture sessions, one after the other. And one of the ways they tortured him was to give him electroconvulsive therapy. Okay, so ECT can, if you're awake when you get it, that can be very frightening. You have a seizure. Now ECT is always done under general anesthesia. It's done with a short-acting barbiturate like Revitol, total muscle paralysis with succinylcholine, so the patient has to be bagged with oxygen during the treatment, and the patient wakes up and feels much better. Typically, ECT treatment is given in a series of 8 to 10 treatments over 2 to 3 weeks. At the same time, the patient is started on antidepressants. So we use ECT for severe depression, as I said, that has not responded to an antidepressant, or when a patient is seriously suicidal and or psychotic. Remember that depression and bipolar disorder can both lead to psychotic symptoms. Okay, so ECT can help the patient. Now, ECT does not work, though, for patients with schizophrenia. Okay. There is a combination disorder called schizoaffective disorder, which is schizophrenia and mood symptoms in one patient, and it can be useful for that. And it is also used for bipolar disorder. Okay. The only contraindication for ECT would be increased intracranial pressure or a recent myocardial infarction. Otherwise, ECT is considered a safe and effective treatment for emergency treatment for depression. And it is safe in the elderly, and it is not uncommonly used in the elderly. It's used in teenagers. It is used in children. Okay. Okay, so certainly medications are a better choice, but sometimes it's an emergency situation. Okay, or the patient has not responded to medications. Okay, the mood stabilizers are next, and the prototype of a mood stabilizer is lithium. And I have to tell you, we really don't know how lithium works either to stabilize mood. There are theories, but we don't know. Lithium is the primary drug used to manage bipolar disorder, to prevent prophylaxis, to prevent elevation of mood, and prevent depression of mood. So bipolar disorder is useful to prevent both of those mood states. It's also used for migraine and cluster headaches. It's also used for patients who are chronically aggressive. It seems to decrease aggression. And it can be added to antidepressants if a patient is not responding to the antidepressant alone. Okay, so for resistant, or what we call treatment-resistant depression. Dangers of lithium. A very narrow margin of safety. We have to have a patient, again, who will be compliant and who will come in for regular blood tests. Okay. So that we have to measure lithium levels. Lithium levels must be within a relatively narrow limit. There are a number of side effects. We see a fine tremor. We see polyuria and polydipsia. That's why thirst is in there. Okay. We also see acne, which, although it doesn't sound like a big deal, is a big deal to patients and has a lot to do with compliance. Hypothyroidism. We also have to check patients every 3 months for thyroid function. Because hypothyroidism is also a side effect. Now, lithium, like the other mood stabilizers, is teratogenic, particularly Epstein's anomaly of the tricuspid valve with lithium. Valproic acid is also teratogenic. It is an anti-seizure medication. It's used, remember, rapid cycling bipolar disorder, which was more than 4 episodes a year. That is treated primarily with valproic acid rather than lithium. It may also be used for the acute manic state. It seems to calm the person down right away. Okay. And we know how valproic acid works. It is a anti-seizure medication because it increases GABA, the inhibitory neurotransmitter in the central nervous system. Carbamazepine is also an anti-seizure medication, also increases GABA. Okay. The reason it's a second-line medication is that it also causes agranulocytosis. So both clozapine and carbamazepine can cause a significant depression of the immune system. Okay. The anti-anxiety agents, we have talked about the benzodiazepines in the context of substance abuse. So benzodiazepines are drugs that are very comfortable to take. They have essentially no side effects, and people take them and their worrying decreases. It decreases worries in just about anybody. And the idea about obsessing or thinking about things repeatedly seems to also be relieved to some extent by benzodiazepines. However, they are, some of them are longer acting, but most of them are relatively short acting, and the anxiety comes back, and it might even come back more than it was before when the patient is going off the benzodiazepines. So it's useful for anxiety, especially if you expect the anxiety not to be chronic. Okay. Some of the benzodiazepines are useful for alcohol withdrawal. They reduce the likelihood of seizures. Some of them have anti-seizure activity, like diazepam. Some of them are hypnotics. That is, they also cause sleepiness. And they are, of course, used in the emergency room whenever anybody has a acute anxiety attack, such as in panic disorder. We know how the benzodiazepines work. We know that they increase the action of GABA. Okay. They are useful, but they also have, and we talked about this, considerable abuse potential. and the potential also for tolerance. That is, the more you use them, the less well they will work. Okay, we have to also caution patients about using benzodiazepines with alcohol because they have an additive effect, and they have a very serious withdrawal syndrome, and we've spoken about that, which requires hospitalization. That is anxiety, agitation, seizures, and even psychotic symptoms. So benzodiazepines have to be used cautiously. They are powerful and wonderful drugs for temporary problems with intense anxiety, but long-term use leads to a syndrome of withdrawal. Okay. Okay. Where are we now? Let's see. Okay, so here are some of the benzodiazepines. There are many of them. We have grouped them by their which ones act fastest and which ones act longest. The fastest acting, the ones that we use in the emergency room, alprazolam, diazepam, cause very little sedation. Flurazepam and triazolam are drugs that are used to promote sleep and because they work very quickly. Okay. The longer acting drugs may be used for patients who have more chronic problems with anxiety. Chlordiazepoxide was the first benzodiazepine, so it doesn't have an AM ending. Clonazepam, temazepam. So a number of these, if they say insomnia is a side effect or common uses, that's the one that most patients with insomnia are taking. Okay, so you need to be able to recognize a benzodiazepine when you see it. Should be pretty easy with their AM endings, except for chlordiazepoxide. Okay, now buspirone is a non-benzodiazepine agent that is useful for patients with anxiety. It, however, doesn't work for 7 days because it doesn't work on the GABA system. Instead, it works on the serotonin system. And the serotonin system, remember, needs to have kind of be primed for weeks before these drugs will be useful. There's no abuse potential for buspirone. It works almost like an antidepressant, okay? That is, it takes a week to work, not as long as an antidepressant, but it doesn't have any withdrawal effects, and it's not potentiated by alcohol. So this is a good choice for somebody with chronic anxiety, and it is indicated in generalized anxiety disorder, okay, because it has essentially no abuse potential. The only trouble is if a patient has ever taken a benzodiazepine, and I mentioned this before, they're going to say, what is this stuff? It's not doing anything for my anxiety. And you reassure the patient it's going to take at least a week to work. The patient says, I don't want this. Just give me a prescription for Xanax. Xanax is alprazolam. So this is useful for people who have never taken the really good stuff, which are the benzodiazepines, although they can be dangerous. Buspirone has no abuse potential, and some patients may be quieted down by that idea that they can take it and they can even drink alcohol with it, and it is a very safe drug. Okay. Okay, remember I told you that we were going to talk about the pregnancy categories? Okay. Let's see. A little note for myself here. Okay. So the FDA, the Food and Drug Administration, categorizes many medications, all medications, based on their safety in pregnancy. Okay. If a drug is in category A, there is absolutely no risk to the fetus or in animal or human studies. Category B is no risk or slight risk to the fetus in animal studies, no risk seen in human studies. Remember, we talked about category B. So that's a very good category. You'll see that none of the psychoactive drugs are in category A. Okay. You rarely can say that the drug poses absolutely no risk to the fetus. So category B is a good one. And if we look at category B, we'll see that clozapine, the star antipsychotic, is in category B, and lorazepam. So those are two antipsychotics that you could use in pregnancy, that you would prefer to use in pregnancy. Bupropion, the anti-anxiety agent we just talked about. Rather, the antidepressant buspirone, and a lot of people get those confused like I just did. Buspirone is the anti-anxiety agent. Bupropion is the dopamine agonist that is an antidepressant. And what is Zolpidem? You'll remember that is the GABA agonist sleep agent. Okay, so these drugs are in category B. Category C, you can see, really is the longest one. This list would go all the way down because it includes all the antipsychotics and antidepressants that are not specifically listed as being in B or D. Okay, so mostly all the SSRIs, the antipsychotics, the cyclic antidepressants, all of those are in category C. And what is category C? That there has been shown to be some risk to the fetus in animals, no adequate studies in humans, but the benefit warrants the use during pregnancy. And most patients are maintained on category C medications throughout their pregnancy. It is much more dangerous to allow a patient to have a psychotic episode or a depressive episode during pregnancy than the possible and nevertheless quite unlikely risk of category C drugs during pregnancy. Category D drugs can cause a risk to the fetus in humans, but sometimes we do use these drugs in pregnancy as well because, again, the risk is not high. Okay, my friends, I think I have catatonia again. So I'm going to take a little bit of a break. And I'm going to log in again. Okay, category C. Category D, and we mentioned that we try to avoid these drugs in pregnancy, and you'll see that there is an SSRI in category D, and that is paroxetine. So we would not use paroxetine during pregnancy for most patients. Okay. Carbamazepine, you'll remember, which is a mood stabilizer, lithium, valproic acid, all are mood stabilizers and all are teratogenic to some extent. Although there are many doctors who use these drugs during pregnancy because the risk to the fetus is relatively small. The benzodiazepines also are drugs that we don't use in pregnancy or we try to avoid in pregnancy if possible. And these, so there is a risk to the fetus, definitely. Category X we avoid in pregnancy. The human fetal risk outweighs potential benefits. So that would be flurazepam, temazepam, and triazolam, which, as you remember, are all hypnotic benzodiazepines. So the hypnotic benzodiazepines, the sedating ones in particular, are absolutely to be avoided in pregnancy. Okay, so we have a choice for category B for many of the drugs, okay? And the question might be, what do we do with patients who have bipolar disorder and have been on one of the mood stabilizers? Well, these patients will be followed and would be given, rather than these mood stabilizers, a number of the atypical antipsychotics are also indicated for bipolar disorder, like risperidone. So we would give the patient an atypical antipsychotic rather than one of these mood stabilizers because the atypical antipsychotics, for the most part, are in category C. Okay. My friends, this is a very high-yield topic. And this is a topic that, as I said, students from other countries will have particular difficulty with, because legal issues are country specific. Ethical issues are very specific to the medical profession, and particularly in the United States. So I'm going to tell you how to answer these questions on the boards, and you're going to get them right. Okay. And I know some of you may have some questions about them. And remember, we are going to follow the rules of the United States Medical Licensing Exam. Okay. So that's what I'm going to be talking to you about, and that's how we're going to answer these questions. Okay, my friends. Okay, now one of my texts has a question. Okay. Okay. I was still catatonic, I suppose. How are we doing? Thank you, my TA, telling me that I was not moving or even appearing in that one. I was invisible. Okay. Okay, so Sharuk, I don't know Sharuk's question. Dr. John? Okay. Okay, so Dr. John is going to answer, hopefully. Okay. I guess the question is can we send out? Okay. That is up to, of course, the Kaplan program. So I'm going to leave it up to the TAs and the others in the administration. Okay. Okay, my friends, here we are, ethical and legal issues. Remember that legal issues involve the law, and legal issues vary by state in the United States, although there is one body that can pull the states all into line, and that is the Supreme Court of the United States, which actually can have in some circumstances. So ordinarily, the Supreme Court of the United States leaves the individual 50 states alone and lets them do whatever they want to do. A case is brought. I believe that there are currently 3 women judges and 6 men, and the judges are appointed by the President of the United States. And judges on the Supreme Court keep their positions until they either retire or die. And there is no mandatory retirement age. So many times, Supreme Court justices or judges will remain on the Supreme Court until they're very, very old, okay? And until they die, essentially. So whoever the sitting president is at that time has a lot of power in appointing a Supreme Court justice. The Supreme Court is probably the most powerful body in the United States. Okay. Okay. So let's take a look at some of the selected important court cases. They may be state cases, but they now apply across the country. Okay. The first case is a case of Karen Ann Quinlan, who was a New Jersey teenager. This is her picture. She was taking diazepam when it was first developed. That was back in the 1950s. And nobody realized at that time that the benzodiazepines had such important interactions with alcohol. And she went out for alcoholic drinks with her friends. Okay. She ended up in a persistent vegetative state because of the combination of alcohol and benzodiazepines. Okay. Her family, when they were told that she would never recover consciousness, asked the hospital to turn off the respirator because they felt that she was very uncomfortable using the respirator. And since she was never going to come back to functioning, please turn off the respirator, which is making her uncomfortable, they asked. Okay. The hospital said, please show us the document that says that's what she would have wanted. Remember, she was over 18. Okay, so she was an adult in the eyes of the law. And the family said, we don't have a document because she was so young. We never prepared a advance directive, as they're called, a living will. They said, but we knew what she would want because she was our daughter. This was the parents. And they said, we know she would have not wanted to be kept alive like this. Okay. The hospital said, did you ever have a conversation with her that you can relate to us? Because a conversation will be as good as a living will if somebody attests to the fact that they had the conversation. People tell the truth in these situations. And they said, no, we never talked about it. She was so young. Okay. Then the court ultimately ruled, after many years of the family trying to get the respirator turned off, that if you did not have that person had not told you really what they would have wanted. People who knew her well could tell you what they felt she would have wanted. Okay? And the family knew her well. They noted what she would have wanted. And that became the substituted judgment standard. That is, you don't have the information directly from the patient, but people who knew her well could supply what we call substituted judgment. Okay. And the respirator was turned off. Unfortunately, she lived for many years more on a feeding tube, okay, and hydration. The family did not ask that to be removed. Okay, Brother Fox, in this case, and you don't have to know the names of the cases, but it's of interest if you want to look them up, okay? This was a case where an individual was in a persistent vegetative state, but nobody knew him well enough to know what he would have wanted, okay? So there was nobody to provide substituted judgment. Only, the court said that only in a case like this where nobody can tell you what he would have wanted, only then can the treatment team make the decision as to what is in his best interests. Okay. So ordinarily the treatment team doesn't make the decision unless there's nobody else to do it. There was no document, there was no indication of whether he would want to be kept alive like that. Okay. So the medical team decided. In the infant Doe case, this is a child born with a tracheoesophageal fistula, a correctable birth defect, and the child had Down syndrome. The parents refused to allow the life-saving surgery because of the Down syndrome. The hospital went along with the parents, the baby died, and that led to a change in the law. Now, parents cannot forego life-saving surgery for their child, even if the child has either a correctable birth defect or mental retardation. The only time, according to the American Academy of Pediatrics, you can forego life-saving surgery is if the child has trisomy 13 or 18 or anencephaly. No brain or a non-developed brain. Okay. Otherwise, the child will be saved. Okay. Roe versus Wade was the abortion decision in the United States. That is where a woman was refused an abortion in her state. This is before abortion was legal. Every state refused abortion, and it was done illegally. The case went all the way to the Supreme Court, and the Supreme Court agreed to take the case. Remember, they have to agree that they want to take the case, and they were interested in making a ruling for the whole country. And Roe versus Wade, in a vote of 5-4, that's how close it was, voted that it is up to the patient to decide whether or not she wants to remain pregnant. And that is when abortion became legal in every state in the United States. Every time the Supreme Court gets a new justice, though, the abortion decision could change because it could go 5-4 if somebody brought a case before the Supreme Court. Okay, so Roe versus Wade was only by a very narrow margin. Every state allows abortion in the first trimester. Some states refuse abortions in the second trimester. Others allow it. And there is no third trimester abortion because, as we all know, infants can live after 25 or 26 weeks of gestation. Okay. In the Tarasoff decision, a psychiatrist in California was treating a man, and the man threatened to kill his own girlfriend. He said, "I'm going to kill my girlfriend." The psychiatrist, and then the patient ran out of the office. The psychiatrist immediately called the police. The police went to the girlfriend's home, but the patient had already killed her. So the psychiatrist was sued by the victim's family, okay, and they won. Now the law in the United States is that you must, if you know your patient poses a danger to someone, okay, and you know who that someone is and can contact them, and the doctor did have that documentation, he could have called the girlfriend, you must warn the victim, the potential victim, directly, not just through the police. So that is the Tarasoff decision. As a physician, you have a duty to warn the threatened party and also to make suggestions as to how they can keep themselves safe. So that's the duty to protect. Okay. So you must make suggestions to that person when you tell them about the threat, like go right to the police station now. Okay. Okay. Let's take a look at our rules now. Here's our first one. Competent patients have the right to refuse medical treatment. And everybody over the age of 18 or 18 plus is considered legally competent to make decisions for themselves. And they can refuse any medical treatment. They have complete control over their bodies. Now, an individual has control over his or her body, but nobody else's. So if a patient needs a blood transfusion and refuses a blood transfusion for whatever reason, and there are religious groups in the United States that believe that blood transfusion is possibly the worst thing you can do to someone, and they don't believe in blood transfusion. One of those groups is the Jehovah's Witnesses, which you may know about. So the patient says, for religious reasons, I do not want a blood transfusion. Does the doctor follow the patient's request? Abraham, yes. Yes, 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 because that individual, yes, is a competent person. They will tell you in the question the patient is competent. Now, there are occasions when patients are considered incompetent, even though the court did not declare them incompetent, but just looking at them or just seeing how they're behaving, you know they're incompetent. And that would be people who are psychotic, that is, they're having hallucinations or delusions. That makes them temporarily lacking the capacity to make a decision. If they've just made a suicide attempt or are suicidal, they can't not refuse intervention. Okay? Or if they're in a coma, that is, they're non-communicative. Okay? Those people will get the treatment anyway. But all other patients, those that are competent, which is all other patients, can refuse any treatment, even if they will die. Okay. So if a patient is incompetent by virtue of the fact that they've been declared incompetent by the court, or by virtue of the fact that they are non-communicative, like in a coma or psychotic, the doctor can rely on instructions that they have given in advance of the need for them, or so-called advance directive. And an advance directive, typically we would like to have a written document But if we don't have a written document, what the patient says to the doctor is enough. That is, the patient gives you instructions prior to the procedure. You follow those instructions. You write them down in the chart. You write everything the patient tells you in the chart. You date it. You put the time. Even if the patient cannot write, even if the patient cannot read, oral is enough. If the patient cannot speak, body language is enough. And you write down what you observed and your interpretation of it in the chart. And that becomes the living will. Okay. A health power of attorney is a document, a legal document, where a person assigns someone else to make decisions for them when they are incompetent. So I might decide that I would like the President of the United States to make decisions for me when I'm incompetent. The problem with that is the person to whom you give the authority must agree to take it in the first place. And since I've never met the president, I don't think he's going to agree to have health power of attorney when I am unable to speak. Okay. Most of the time, the power of attorney will be given to the spouse, but not always. And if somebody designates another person to have power of attorney, and it is a legal document that is appropriately written up, that person becomes the patient when the patient becomes incompetent. Okay. So that is the health power of attorney. The thing that's important about these, that is which one beats, as we say, which one wins if you have both of them, is whichever one is the most recent document. Okay. So the most recent document beats all. Okay. So if the health power of attorney is dated in January 2014, but the patient has told the doctor what he wants in May of 2014, the oral living will trump the power of attorney. Okay, let's take a look at questions. Now we're going to start doing a lot of questions. Remember that we have lots and lots of questions. I have hours worth of questions for you, my friends. And we start with lots and lots of questions in this section, in the ethics and legal issues. So let's take a look at this one. Prior to a dangerous operation, a patient asked the doctor not to put him on life support. Okay. Just one second. Let me just answer a question here. Mohammed is asking, what about prisoners? Okay, can prisoners refuse treatment? And the answer is yes, they can. Yes, they can refuse treatment unless they're psychotic or in a coma. Prisoners, by the way, cannot be used in research studies because they don't have the freedom to say no, essentially. So it is unethical to use prisoners in research studies of drugs, for example. Okay, what about if the patient is sometimes okay and sometimes not oriented? We ask the patient when they are competent. So if somebody is in a coma and wakes up from the coma, we ask them what they want to do, and then we follow those wishes. That is the most recent wish of the patient, as long as they're competent. Did not get the last one. Okay. Sharuk, I'm not sure which one you didn't get. Okay, so just give me a clue, a couple of words, so that I'll know what you want me to repeat. Because I'm saying an awful lot and talking all the time. Okay, Sharuk? Okay. And he's typing away. Okay. Okay, so I'm going to wait. I think what we'll do is we'll continue on with this question, and I'll wait for Sharuk to put his question in the box. Okay. So let's finish this question. We'll put it on the timer when we finish it. Okay, so during the surgery, the patient requires life support. So he asked the doctor not to put him on life support. Rather, he asked the doctor not to put him on life support. The doctor writes that in the chart. During the surgery, he requires life support, and the son comes up with a written will 2 years ago that the patient wrote saying, "Do whatever you can to keep me alive." What should the doctor do at this time? Okay, now a hospital chaplain is a religious person who deals with religious issues in the hospital. Put the patient on life support. Do not put the patient on life support. Contact the hospital ethics committee. Get a court order to put the patient on life support. What should the doctor do? And I'm going to take a look at Sharuk's question. Okay, Sharuk, now I'm not sure which is the last slide. Okay, let's leave this up for a minute so everybody can answer. A little bit more detail would be needed. Okay. Okay, I'll go to the previous slide. As soon as we finish this question, I'm going to go back and see which one you folks are interested in looking at again. Okay, so here, let's see how everybody's doing on this. I see you doing quite well. Not perfect, but quite well. And the answer is C. 60% of you got it right. Do not put the patient on life support because the patient has given you an oral living will telling you not to put him on life support. You follow the patient's wishes. A document that was written 2 years before is too old. You have the patient's most recent wishes. Okay. Okay, my friends. Let me go back here and see the last point on the previous slide. Okay, and do you mean this one? Is it health power of attorney? Say yes or no? Yes? Oh, fantastic. Okay, okay. So this is a document that says, I do want life support, I don't want life support, I will accept pain medication, I won't accept pain medication, I will accept blood transfusions, I won't accept blood transfusions. So that's the living will, written document. Power of attorney is a person that you have written a document about and said, this person makes decisions for me when I am unable to do so. Okay? So that is a health power of attorney. It is also a document. The person that you assign, though, to make decisions must agree to sign the document as well. Okay? Okay. Okay, so we assume that patients are competent once they're 18, unless they have recently made a suicide attempt, and we talked about this already. They are psychotic, or they are unconscious, or in such a state that they cannot communicate with you. Okay? So if they cannot communicate with you, we cannot assume they're competent. Okay, so they're in a coma, typically. That's why they cannot communicate with you, or in a stupor, okay, which is just less than a coma, but still not able to communicate. Okay. When surrogates make decisions for the patient, that is when somebody assumes the responsibility of making decisions, they should use the following criteria and in this order. Okay. So most importantly, has the patient said anything to you in the past? Do you have a subjective standard or a document? Remember with Karen Ann Quinlan, we did not have a document. Okay. There was also no discussion. We didn't have number one. If you don't have number one, you go to number two. And that's when the doctors ask the parents, what would she have wanted? What did she tell you she would have wanted? Okay. That is, if you don't have the actual, you haven't actually had that conversation with her, what do you think? You knew her very well. What do you think she would have wanted? That's a substituted judgment standard that was used in the Karen Ann Quinlan case. If you don't have that, only then, and I mentioned, can the treatment team decide what is best for the patient. So only when you do not have anybody who knew the patient well enough to tell you what they would have wanted. Okay. Let's look at this question. This is more like a real board question because it's really long. I've shortened many of the others. Okay, we have a 62-year-old man, and we're going to take a break right after this question, who has been in a serious car accident. He's brought into the hospital. After he's stabilized, medical evaluation reveals that he will never recover consciousness, but will instead remain in a vegetative state. Because the patient has never discussed his wishes, someone must make a decision about whether or not to continue life support. Prior to the accident, the patient was declared the legal guardian for his wife, who has Alzheimer's dementia and lives in a nursing home. Now, people only have a legal guardian if they have been declared incompetent, and the patient, the legal guardian for his wife. The patient's sister, with whom the patient lives, tells the doctor that her brother would not want to be kept alive in this state. The patient's adult son tells the doctor that his father would want to be kept alive at any cost and that life support should be continued. Most correctly, who makes the decision, Ray, continuing life support? The ethics committee, the wife, you can start the counter, the son, the physician, or the sister? This is a tough question and a very typical board question. Well, more of you can take a chance. Okay, we have 38 students in the room at the moment. Let's get some more responses on this one. Take a chance. If you get this wrong this time, you will never get it wrong again. I promise you that. Okay. Okay, time's up. And the answer, my friends, is, let's see how many of you got it right. Only 18% got it right. That is the son. The son makes the decision. And let me show you why. Because there is an order that you follow. The priority order that makes this determination is the spouse. But remember that the spouse is incompetent, so she cannot make any decisions for herself or for anybody else. The adult children, so the son is the adult child that came forward. If there are living parents, they would be third choice. Siblings are fourth. Other relatives are fifth. Okay, so the adult children make the decision. That is, children that are 18 plus. Okay, and I'm going to put the question back on now for the break. Okay, but remember, spouse, adult children, parents, and then siblings. And if you have any questions, please type them in during the break, because I'm sure you have a few questions about this. Okay, now it's time to take our break. Okay, we're back again. I've left this question up at the break. Let's see who asked questions about it. I don't have any questions. So everybody is comfortable with that answer. That is the way to answer. Some students have asked, okay. They say, well, he lives with his sister. Won't the sister know him better? Well, we all know that sometimes people can live with another person and really have no communication with them. So just living would indicate that she is the one to make the decision, okay? It is the adult children that will make the decision. Just follow the rule, okay? Now, a couple of questions. What if two adult children say two different things? That is, the son says one thing, the daughter says another thing. That must go to the hospital ethics committee. They will make the decision as to who should ultimately make the decision. You cannot decide. Males and females have equal rights. It doesn't. The age of the adult child is irrelevant. Okay? So if one is 35 and one is 45, you can't make that decision just because one is older. That has to go to the hospital ethics committee. Okay, so two people on the same level say different things, goes to the ethics committee. Similarly, if the two parents of this adult say two different things, it goes to the ethics committee. Okay, or two siblings. Ideally, you want the family to all agree on what is going to be done. So calling a family meeting is sometimes a choice on the questions. Calling a family meeting would occur even before you make a decision. Okay, so calling the family meeting would trump all of them. Okay. Okay, rule number 5. Okay, you know the older does not have any special rights, doesn't have any rights over the younger as long as they're both adults. And by the way, adopted children, children who are legally adopted, have exactly the same rights as biological children to make decisions. Okay, so adopted children have the same rights as biological children do. Okay. Okay, a feeding tube is a treatment that can be withdrawn at the patient's request. Remember that patients can request the removal of any life support, whether it's a feeding tube or a breathing tube, life-saving food and water. Competent patients can refuse any of these supports. Okay, and the doctor will comply with the patient's request. Okay, that would be the ethical thing to do. Let's look at this question. Okay, so ALS, of course, is amyotrophic lateral sclerosis, Lou Gehrig's disease, a terminal neurological disorder. A competent patient with ALS asks the doctor to turn off life support and let him die, and the doctor does so. Is what the doctor did legal, ethical, both, or neither, my friends? We can start the counter. Okay, you guys did really well on this question. The answer is it is both legal and ethical for the doctor to follow a competent patient's wishes. There is no ethical distinction between refusing to start a treatment and removal of a treatment or a support. Neither one of them is euthanasia or assisted suicide. Okay? Let me tell you now what, because it is harder for you to ask me questions than when I'm teaching the live class. Euthanasia is defined as the doctor administers something to the patient with the purpose of shortening their life, like a very high dose of an opioid. Okay. Basically, the doctor kills the patient. That is euthanasia. Okay, even though it's for humanitarian reasons, it's still euthanasia. That is illegal everywhere in the United States, in every state. Okay. Assisted suicide is when the doctor gives the patient a means to kill himself. That is, the doctor gives the patient medication that will kill the patient and tells the patient this medication, if you take this many pills, will kill you. Okay, that is assisted suicide, and that is illegal in the United States also. However, a few states, 4 I think at the moment in the United States, allow assisted suicide under certain very special circumstances like terminal illness. However, according to what we must follow for the United States medical licensing exam, assisted suicide is also illegal in the United States. Okay? Okay. So the answer to this question was, and I told you, it is both legal and ethical. Okay, let's get to some more rules now. Do nothing to actively assist the patient to die sooner. That is euthanasia or assisted suicide. Okay. Now, only the doctor can decide when the patient is dead. That is, a licensed physician must sign the death certificate, which attests to the death of the person, and if it is known at that time, the probable cause of death. Okay. So if a patient arrives in the emergency room of a hospital already dead, but there hasn't been a physician with that person, the doctor must come in, examine the body, and fill out the death certificate. Okay. Okay, let's take a look at this question. A terminally ill patient is in intense pain, but the doctor knows that if he gives an opioid, the patient's respiration will be suppressed and he will die sooner. What should the doctor do? So this patient is in very intense pain. Okay, it's probably a cancer patient, some other terrible disease. Tell the patient the risk, and with his okay, give him the amount of opioid needed to relieve the pain. Give a small dose to partially relieve the pain. Do not give the opioid. Give NSAIDs, nonsteroidal anti-inflammatory drugs only, or ask the patient's wife for permission to give the opioid. Okay, my friends, let's see how you do on this one. Let's get more of you to chime in here. Okay, we have 39 people, students now in class. Thank you. Okay, my friends. What should the doctor do? Let's see how you did on this. Okay. 64% of you got it right. The answer is indeed A. That is, tell the patient the risk, but your purpose in giving the patient the opioid is to relieve his pain, not to shorten his life. Remember that your purpose cannot be to shorten his life, because that would be assisted suicide, which is illegal in the United States. Here, you're giving the medication to relieve his pain, and we always relieve patients' pain, particularly if they are terminally ill. We do not let patients suffer when they are terminally ill. Okay? So we give him the high dose of opiate even if it will cause him to die sooner. Okay. Okay, never abandon a patient. Once you put a patient's name in your appointment book in the United States, that is, a patient will call for an appointment, you agree to see the patient and give them an appointment, that person is your patient until they decide that they don't want you to be their doctor anymore. You cannot get rid of them for any behavioral reason. Okay, so no matter how offensive the patient, even if they make sexual advances, even if they don't pay you, once you have accepted them as a patient, they are your patient. Okay, so you have a right, though, to refuse to take patients who cannot afford to pay you as a private doctor in the U.S. So before you sign that patient into your appointment book, typically you will ask the patient, do you have health insurance, or are you going to pay for this on your own? You can refuse to treat the patient who says, I don't have health insurance and I cannot pay for it on my own. You will tell that person to go to the emergency room of a local hospital. Because in the United States, emergency rooms are required, and I mentioned this, to stabilize every patient that comes to the door. They cannot turn this person away. You, as a private physician, though, can turn that patient away. Now, what if you accept a patient who has health insurance, and a year later, the patient loses his health insurance and has no money to pay you? Can you send that patient to the emergency room? And the answer is no, you cannot. That person is your patient. That's right. No, 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 absolutely. That patient is now yours. Patient makes sexual advances. We know how to deal with that. What do we do when a patient makes sexual advances? We call a chaperone into the room. Very few people will continue to be seductive when somebody else is in the room. Okay, so let me just tell you a couple of rules with respect to chaperones. In the United States, you will talk to adult patients alone, unless they are offensive, aggressive, or have made sexual advances. In those instances, you will talk to adult patients with a chaperone in the room. Okay? Every adult patient is examined with a chaperone in the room, no matter if they are male or female, right? Or you are male or female. You're remembering this now, right? Okay. So we always have a chaperone in the room when we examine any patient. Okay. With children, okay, with children below the age of puberty, we have the parent in the room when we interview the child, and the parent will also be in the room when we examine the child. Okay, this is for young children. Okay. Once a child has reached puberty, okay, we will interview the child and alone and examine the child with a chaperone in the room, not the parent. Okay, so we speak to teenagers alone, and we interview them with a chaperone in the room. That is, we treat them like an adult once they are past, once we see signs of puberty. Remember also that you can treat, and we will talk about this, treat a person who is 14 and over for any sexually or drug-related condition without parental consent or notification. Okay, my friends. Okay, so we never abandon a patient. I like this board question. I think it's a fun question. I don't know if you'll think so, but I think so. Okay. A 38-year-old patient asks her primary care doctor, Dr. 1, for a referral because she's moving to a different city. Okay. I'm just making a note. Now, Dr. 1 refers the patient to Dr. 2, an old medical school friend in the new city. When the patient goes to Dr. 2, Dr. 2 notices that the patient seems depressed and anxious, so he refers her to Dr. 3, who is a psychiatrist. Dr. 3 will be out of town for a while, so he tells his service to refer the patient to Dr. 4. Dr. 4 has no time to see the patient, so he tells his office staff to refer her to Dr. 5. Ethically, which step in the referral sequence was least appropriate? Again, this is not a legal issue. Referrals have nothing to do with the law. You're not breaking the law in any of these circumstances. But which one is least ethical? Okay, my friends, let's start our... Can we start the timer? Thank you. It's kind of a harder question, right? This was indeed a step 1 question. Okay, well, I have a question over here. I didn't hear for an adult normally without a chaperone. Okay, normally we interview. Remember, there's an interview and a physical examination. So we interview a patient alone, except if he is offensive. That is correct. Then we interview and examine him with the chaperone. Haya, is that the answer to your question? Okay. You're welcome. You're welcome. Okay. Okay, well, let me take a look at the timer here. Let's see what's going on. 62% of you have chosen D, which is not correct. Okay. The correct answer is B. Okay, the correct answer is B. So only 4 of you got the right answer on that one, B. Okay. Okay, now a couple of you picked A. Doctor 1 can refer the patient to Doctor 2 because the patient is moving to a different city. You're not going to keep a patient who's moving to a different city. Okay, so that's not right. C is Doctor 3 will be out of town for a while. If a doctor will be out of town for a while, he does not have to take on a new patient. Many of you chose D, which is if you have no time to see a patient, you do not have to take them on as a patient. Okay, he has no time to see the patient, so he refers her to Doctor 5. Okay, he's never seen this patient. This is a new patient. He does not agree to take her. Okay, the answer is B. Doctor 2, the new doctor, goes there and notices that the patient is depressed and anxious. You do not refer depressed, anxious patients to a psychiatrist. You evaluate why they are depressed and anxious. There are many, remember we talked about this, medical conditions that can lead to depression and anxiety. You want to do all the physical workup on the patient and medical laboratory testing on the patient. Perhaps the patient has hyper or hypothyroidism. Perhaps the patient has pancreatic cancer. You're not going to send the patient to a psychiatrist. As a matter of fact, on the boards, remember, you never pick that choice. So how are we doing, my friends? Okay. How are we doing? Okay, has everybody gotten it? The answer is B. The answer is B. Okay, the answer is, you can refer patients. Dr. 4 did not do anything wrong when he referred the patient to Dr. 5 because he has no room in his calendar. Okay? The problem here was referring to a psychiatrist when the patient had some behavioral issues. That was the problem. Okay? Good. Okay, how about this one? A pregnant physician refuses to treat a patient who tested positive for TB because she is afraid of infection. Her refusal to treat the patient is, and we have the same choices as we had in the other question, legal but not ethical. So legal, ethical, both, or neither, my friends. Let's stop the timer. Okay, Shireen, I will answer your question as soon as we finish this one. Okay. Okay, we're counting down. We have a few seconds to go. Okay, let me take a look at your answers. You have mainly chosen answer A. Okay. That it is legal but not ethical. And the 50% of you that chose that are indeed correct. Okay. So you can refuse to treat a patient for any reason. Okay. Legally, you will not go to jail for that refusal. However, the Board of Medical Examiners of your state you practice in may censure you and at the very worst take away your license for this. Okay, so you are ethically expected to treat patients who have communicable diseases because you are expected to know how to protect yourself and use precautions for infection control. So this is legal, but not ethical. How are we doing? Okay, so Shireen has asked me, when do we refer to a psychiatrist? On step 1 of the USMLE, the answer will be never, okay? You will always do a medical evaluation of the patient before you refer to a psychiatrist. And in the US, most patients with depression and anxiety are managed by primary care physicians. Primary care physicians write prescriptions for SSRIs. They write more prescriptions for SSRIs than psychiatrists do. Okay, so the primary care physician maintains the anxious or depressed patient. Okay, it is only when a patient does not have any medical explanation for psychotic symptoms. Okay, there's nothing medical, there's no high fever or disease, that the doctor will refer to a psychiatrist. Okay. Shireen, have I answered your question? You're welcome. Okay. Okay, and we've talked about this in another context. Keep the doctor-patient relationship within bounds. No romantic relationships with patients or former patients. You don't date, don't have relationships, romantic relationships with family or friends. You do not treat family or friends because you are, there may be some transference or countertransference issues which might affect your judgment. Okay. So when a family member needs a physician, we can certainly find a physician for that family member, but we do not take the person on as a patient. We also do not have as patients employees. Employees cannot be patients of the doctor. Okay, and they've asked that on the boards. You will find a doctor for that employee. So they had a question where they asked, can a nurse asks the doctor to be her primary care physician? Can the doctor do it? Well, we know the doctor cannot be her primary care physician. Some of the choices, though, were he can give her an occasional prescription, which is, the answer to that is no also. He can treat her but not charge her, and that is also wrong. Because employees have a special relationship to their employer. That is, they cannot tell the employer all the details of their health issues. They cannot tell their employer, for example, about their substance abuse or alcohol use or sexually transmitted diseases because it can affect their job state. Okay, so it is what we call a conflict of interest. Okay, and also no valuable gifts from patients, and we talked about that. That is, things that can be sold. Okay. Stop harm from happening if possible. Don't let a patient harm someone else. You will call the police and the threatened party. We will always make recommendations that the patient who has a disease not be in contact with other people if it is a dangerous disease. We will report certain diseases to the state with the patient's identifying information. That is the law. Okay. Okay, the notes say AMA guidelines say for at least 2 years. Shireen, I know that that's what the notes say, but let me tell you, for the boards, it is never, never romantic relationships with patients. Never. Okay. Okay. Our rule number 11, always obtain informed consent. Okay. And that has 5 parts. Informed consent means you inform the patient about the procedure, what you're going to do and why, the benefits and the risks, and also the alternatives, and also that they can withdraw consent at any time. So even after a patient consents to a procedure, they can change their mind when you're just about to do it. Okay, so they can always remove or take away the informed consent. Okay. Unexpected findings during surgery. The key here is, if you stop the surgery, would the patient be in danger of dying? Okay. If you didn't fix what you find, could the patient die? Or is it something that you just happen to have seen in the course of a surgical procedure, which is not life-threatening to the patient? In the latter instance, you would close the patient up and get consent to biopsy that finding or examine that finding further. If it is an emergency, you will not put the patient in more danger by closing them up, but you will correct the problem in an emergency situation. Okay, my friends? And now answer this question. Okay. A surgeon is operating on a patient for a tubal pregnancy, but when he gets in, he finds that a hot appendix, an infected appendix, is causing the symptoms. What should the doctor do? Remove the appendix immediately, let the patient wake up and ask for consent, ask the husband for consent, or consult the hospital ethics committee. Okay, my friends, let's start the timer. Let's see. I'm looking at whether you have any questions. Is this a good time to ask them? Okay. Okay, our time is up. What does the doctor do? 76% of you have chosen choice A, and that is the correct choice because this is an emergency. An infected appendix is not like a possibly cancerous tumor. That is, a hot appendix is an emergency, and you take it out. Okay. If it is something that is non-emergent, you don't touch it. Okay. You discuss the findings with the patient, and then you both decide on a course of action. Okay. Okay, let's look at this one. An attending surgeon asks a first-year surgery resident to obtain informed consent from a patient for a surgical procedure. The resident knows little about the surgery or its risks and complications. This is a position you don't want to be in as a resident, but you frequently will be. At this time, the resident should obtain consent and answer any questions he can answer, obtain consent and tell the patient to talk to the attending later if she has any questions, ask the attending to get consent from the patient himself, or ask the nurse to get consent from the patient. Okay, my friends, what do you do? What are we going to do here? Time is up, and you folks have done very, very well on this question. 61% of you have gotten it right, and the answer is C. You cannot ethically obtain informed consent if you don't have the information for the patient, because an informed patient must have all the information, like the risks, the benefits, what will happen if they don't consent, all of these things you do not know. So you have to ask the attending to get consent from the patient himself. Hopefully the attending knows all of this. Okay. Okay, but it is up to the attending to get consent. And I know that you are told, don't bother the attending, make decisions for yourself. In this situation, it would be unethical for you to do that. Okay, special rules apply with children. And we've talked about some of these issues. That is, people under 18 are considered incompetent unless they fit into one of these four categories. These four categories make up an emancipated minor. That is, a person. Okay, so a person is a minor unless they are married, raising a child, even if they're living with their parents, if they have their own child with them, in the military, or self-supporting. They would be an emancipated minors. Okay, they would be an emancipated minors. Now, even if they are not emancipated minors, that is, they are living with their parents and dependent on their parents, they still can make decisions for themselves in areas concerning sex or drugs. We've talked about this. They can obtain STDs, treatment for STDs. I know they can obtain STDs. They can obtain treatment for STDs, substance abuse treatment, birth control, and prenatal care without parental notification. The parents cannot even be told that the girl is pregnant. Okay, you have to keep that information confidential. Now, if a teenager has a hot appendix and you identify that, you have to talk to the parents about it. That is, before they're 18. But all of these things we keep confidential from parents because we want teens to be able to come to us without fear of being exposed to the parents. Okay. A 12-year-old child is injured in school and the wound requires immediate suturing. The parents are on vacation and are out of contact, and an aunt is caring for the child. What should the doctor do? Ask the aunt for permission, ask the child for permission, wait until you can contact the parents directly, ask the school principal for permission, or suture the wound without obtaining permission. Let's start the timer. Okay, my friends. Okay, I'm doing very well on this question. 72% have answered correctly. The answer is suture the wound without obtaining permission. Now, some of you picked ask the aunt for permission. The aunt has no more rights to make decisions for the child than any babysitter would. Okay, so the aunt has no standing. Only the legal guardians can make decisions for patients who are children, okay, or adults who have been declared incompetent. Parents are automatically the legal guardian for their children until the age of 18, okay, and they're the ones who make the decision. No one else can make the decision, okay. Now, if the aunt were the legal guardian and there were no parents, or the parents' rights were taken away, then of course the aunt could do it, okay. But here, the parents are just on vacation. Okay, a 22-year-old man with schizophrenia is brought to the emergency room from an inpatient psychiatric facility a half an hour after accidentally cutting himself while slicing bread. The patient has a 6-centimeter cut on his hand which requires suturing. He refuses treatment for the cut and states, "I know I have a thought problem I take medication for, but I never know who to trust. I want to wait until my parents get here. I know my hand can get infected if I wait too long, but I don't think a few hours are going to make a big difference. What is the best course of action for the doctor to take at this time?" Do not treat and determine if the parents are on the way. Do not treat until a court order is obtained. Treat because the patient is in a psychiatric hospital. Treat because the patient shows signs of paranoia and is thus incompetent. Okay, my friends. Oh, we turned. Okay. We'll let you have a few more seconds than the timer indicates. Well, here we have a patient with schizophrenia who is in an inpatient hospital psychiatric hospital. Accident. He explains to you why he's refusing treatment. Can he refuse treatment, of course, is the question here. And the answer is A. 33% of you got it right. Do not treat and determine if the parents are on the way. Okay? This patient, although he has schizophrenia, is not currently psychotic. He understands the ramifications of his refusal. Okay? He knows that he sometimes is very suspicious of people. So he wants to wait. And you do wait. You wait until the parents get there. Okay? Okay, any questions on that one? The number of you picked. The patient has all his civil rights, even though he's in a psych hospital. Remember, I told you that the judge comes to the psychiatric hospital. The patient retains all his civil rights, that is the right to contact people, the right to have people help him make decisions. The only right you lose when you are in a psychiatric hospital is the right to come and go. Okay. Okay. And parents cannot withhold life or limb-saving treatment from their children. Only for themselves can they withhold such treatment. Jehovah's Witnesses, their children will get the blood transfusion if it is the standard procedure for their illness. They stay away from laws that differ by states and tend to go by federal law. Let's look at this one. Parents of a 9-year-old child with leukemia are offered a chance to enroll the child in a randomized study of a new experimental treatment developed by a respected pediatric oncologist. The child has failed to respond to 3 prior treatments. The parents refuse to allow the child to have this treatment. At this time, the child's doctor should, let's start the timer, get a court order, follow the parents' wishes, administer the new treatment to the child without permission, warn them that they can be prosecuted if they refuse the treatment. What is the answer, my friends? Okay. Okay. Let us see what the correct answer is here. The correct answer is 53% of you got it, is B, follow the parents' wishes and do not give the child the treatment. Why do we not give the child the treatment? Remember, parents cannot refuse life-saving standard treatment for the child. What's wrong with this picture? No, it is not because it's not life-saving. Faisal, you got it first. Yes, because it's an experimental treatment. You cannot compel parents to give a child an experimental treatment. You can only compel parents to utilize standard treatments. Okay, so it's experimental. That's the reason, right? And not because it's randomized either, okay? And it may very well be life-saving. It may be the only chance the child has, but the parents have the right to refuse because it's experimental. Okay. The Good Samaritan laws. In the United States, there are laws that limit liability when a doctor helps at an accident. Okay? And that's based on something that appeared in the Bible. That is that an individual helps another person without expectation of any reward. Now, there is no law that says you do have to stop to help. You can keep walking on your way at an accident. However, ethically, you are expected to help if you are able to. That is, you are not impaired yourself. Okay? And if you do stop, you're protected as long as you do something that you have been trained to do, like CPR. You do the standard procedure for that condition. And you don't act like Dr. House. I'm sure you have seen House on television, okay, which is a doctor who never follows the rules and does everything he wants to do. Okay, he doesn't follow the standard procedures most of the time. You have to stay with the patient until you are relieved by another physician. So if emergency people come on the ambulance to take the patient to the hospital, but none of them are a physician, and you are, you have to go to the hospital on the ambulance with the patient until you can turn that patient over to a licensed physician. Okay. And you can get no compensation for helping the patient in an emergency. That is, don't even take the chickens. Don't even take the flowers. Okay? No compensation at all. You have to do this with the understanding that there will be no compensation. And if the patient tries to give you compensation, you have to say to the patient, it would be unethical for me to take anything for helping. Okay? Now, the only time that becomes an issue is if there's a bad outcome when you save someone in an emergency. In the United States, somebody dies, the family may sue the doctor who helped, claiming that that doctor made the patient die. But if the doctor was acting as a good Samaritan in an emergency, there cannot be a case against the doctor. Okay? Unless the doctor did something like Dr. House that he was not or she was not trained to do. So you may have to produce your certificate that you obtain when you learn CPR. Okay? But if you are a licensed physician, we know that you would have such a certificate. Okay. Confidentiality is absolute. We don't reveal information about patients unless the patient is a threat to another person or themselves. If the patient has an infectious disease that is reportable, we report that to the state. We do not report that to the contacts. We don't report it to patients who have been exposed. The state will do that for us. Okay? So the doctor does not inform exposed parties. It is the state that will inform once they have received the information from the doctor. Oh, how about this question? This one is a toughie. Okay. Parents want to know if their fetus has a risk of cystic fibrosis. The test finds that the father is not the biological father. With respect to this information, the doctor should tell only the mother, tell only the father, tell both parents, or keep silent about the maternity finding. And this is an ethical question. What is ethically the best thing to do here? Okay. Okay, well, I imagine that 30 seconds has gone by. And this is a tough one. I see you're all jumping around. Everybody's going different directions here. Okay, we have equal numbers picking 3 different choices because this is a difficult question, and this does differ by culture. Okay. And the way to answer that on the USMLE is D, keep silent about the paternity finding. The finding does not directly relate to the question, which is, does the child have the risk for cystic fibrosis? Okay. That question you do answer for the family. Yes or no. You keep silent about things that were discovered, as we say, serendipitously. That is, just by chance, in the course of medical examination. If the answer could prove difficult for the patients. And this is not related to the health, okay, of the fetus or the parents. Okay. So the answer is keep silent about the paternity finding. Keep silent about any finding that is not going to affect the health of the patient, okay, and is not part of the question that you have been asked. Okay. Well, Ibrahim, you have a question mark, but I don't know what your question is. Okay. Obviously, there is one. So, my friend, please type it down for me, and I will try my very best to answer it. Okay. I'll take a peek over there in just a minute. Okay, let's continue. Okay, you're stunned with the answer. Okay, and I'm sure a lot of people are, well, maybe not stunned, but they're surprised by the answer. But that is the rule. If you find something unrelated. Let me tell you another one. Another rule that's related to this. We talked about the fact that if parents want to know if the child has a genetic disease, and here we have this child, where they want to know if the child actually is carrying the gene for cystic fibrosis. But parents may want to know whether the child will develop a disease in adulthood. Okay? It is the child's right to know that information when he is an adult. The parents do not get that information when the child is a child. Okay, so that would be something like Huntington's, and we talked a little bit about that already. Another question was parents want to know if their daughter has a risk to pass on mental retardation because she has Fragile X. Is she carrying the Fragile X gene? Okay. Do the parents have the right to know if the daughter has the Fragile X gene when she's a child, when she's 9 or 10 years old? And the answer is no, because it's not something that will manifest itself in childhood. And the person herself can be tested or not when she is an adult. Okay? Ibrahim, if you have any more specific question on that, please type it up for me. I don't want you to remain stunned. Okay? We have more to do today. Okay, my friend. Okay, so patients, this is do not resuscitate. If a patient says, I do not want to be resuscitated, that is written in the chart and that acts as a living will. The doctor should follow that living will. However, if the patient hasn't told anybody DNR or written a DNR, you resuscitate the patient. Okay. Patients who are committed, that is, means they're in an institutional setting against their will, retain their rights, and I told you about that, that the judge comes to the inpatient unit of our hospital every Wednesday to listen to patients who are being held against their will, to decide whether or not to release them. After interviewing them and interviewing the staff and the physicians, the judge makes a ruling. Okay. We detain patients to protect them from others, and we've talked about that. We take patients, professionals away from patients if they pose a risk to them. Okay, so patients who pose a risk to others or doctors who pose a risk to patients, we use whatever mechanisms we have, and usually that is reporting the individual to keep them away from patients or others. And this is a picture of Mother Teresa, who was a person who spent her whole life, really gave up her whole life to help poor people. And she was considered in the Christian religion a saint because she did such wonderful things. So ideally, we would all behave wonderfully all the time and do everything that is ethical. And we certainly will try. We focus on what is the best ethical conduct. Remember, it's quite simple to follow the law, but it is much more difficult because the ethical standards of the profession, as I said, always exceed your legal obligations. Okay, and now I have one last question for you before we go into our general questions. Okay, And before we take a break, a clearly competent 25-year-old woman is 7 months pregnant. She tells the obstetrician that over the past year she's been using illegal IV drugs and has had at least 5 different sexual partners. The doctor explains the risks to her fetus if she's HIV positive and how prenatal treatment with AZT can reduce the risks. Okay. He then suggests that she be tested for the virus. Okay. The woman refuses to be tested. Okay. Now the question is, what is the most appropriate action for the doctor to take? So this is a pregnant woman who is at high risk for HIV because she has had multiple sexual partners and is an IV drug abuser. What should the doctor do? Perform the HIV test on a blood sample obtained for another purpose. Give the patient a prescription for AZT. Refer her to another obstetrician. Note in her chart that she's refused to be tested and continue caring for her, or get a court order to do the HIV test. Well, my friends, what do you think about this question? Okay, let us see how you did on this question. 50% of you chose choice D. So although you also chose E and A, one person chose B. The answer is indeed D. Okay, that is, note in her chart that she's refused to be tested and continued caring for her. You cannot go against her wishes. Okay. People can refuse necessary tests or treatment for themselves. And I know what your question is going to be here. What about the fetus? Okay. How about the baby? And now I'm going to say something that you'll remember when you take the USMLE. The fetus has no rights. Okay. Until a child is born, the mother makes all the decisions. Okay. The child is not an entity until it is born. Okay. It is standard care, but she can refuse anything for herself, and the fetus has no rights. Okay, my friends, I'm glad you see it. The answer, Faisal, good. It's a tough problem. It is a hard problem in the United States. And many states have tried to play around with this. They have said, you know, you can do something, you can test the mother for drugs, you can give the child, but the Supreme Court of the United States says, no, you cannot. It is the mother's right to decide. Remember, the mother's right to decide on anything, and the fetus has no rights. Okay. Okay, what about this one? What about after the baby is born? Can the mother refuse the HIV test for the child? She says, you're not testing my baby. I refuse to allow it. Can she refuse? Yes or no? So we have an A or B here. Let's give you your timer, and you only have an A or B choice. Can the mother refuse the test for the child? Oh, I like what I'm seeing. I like what I'm seeing. Okay. Okay, very, very nice. The answer is no. She cannot refuse the test for the child because once the baby is born, it is a little citizen of the United States, okay? And no one can refuse necessary tests or treatment for a child, not even the parents. Okay, beautiful, beautiful, everyone. Okay, now we're going to take a break, and then we're going to come back with lots and lots of questions. See you in 10 minutes. Okay, welcome back. Now we're going to do lots and lots of questions, your bonus questions. Okay. Usually when I have a live class, well, I'm sure you're all alive, but I mean a class of students that I'm talking to, um, I have them read the questions, and then I have teams of them answering the questions. Okay, so they kind of get put on the spot with respect to answering the questions. And I have to tell you that just last weekend, I did a program in Washington, D.C., and in my class I had approximately 50 students from Saudi Arabia. Okay, and we had a very good time together. So in a way I can anticipate some of your questions, which is what I'm trying to do since I cannot see you myself. Okay, so I think they got a lot out of it. I hope that you're getting a lot out of it. And please just type in some questions for either me or for the TA to answer, and we'll be pleased to answer your questions. Okay. Okay, let me just shrink this down a little bit. Okay, good. Now the first questions that we have are based on our statistics and epidemiology, so you have to get your brain all the way back there again to 5 days ago. Okay, and my pointer, I have lost my pointer. It only comes in when it is summoned. Ah, thank you. Do we have something other than a pointer? Something sort of nicer to use? I'm sure we have other indicators. How about a different color pointer? Something different to show us that we're all finished with our basic information and now we're just going to do questions. If not, we'll just keep the green pointer. Okay, that's all we have for now. Thank you, Carrie. Okay. Okay, so here, 2 separate randomized double-blind trials. So that is really the best thing that you can possibly do is when you're doing a test for a new drug is to have a randomized double-blind trial done to see if the administration of vitamin C after an MI decreased the risk for another MI. Both trials show that vitamin C reduced the risk by 5%. This reduction was significant in one trial, P was less than 0.05, but in the other it was not significant. The best explanation for this difference between the results of the 2 trials is that, okay, and we can start the timer, the researchers were blind in one trial but not in another. Randomization did not evenly distribute the risk factors. The sample sizes in the 2 trials were different. There was a placebo effect in one trial but not in the other. Or the concentration of vitamin C was different between the 2 trials. Now remember, it says that these 2 trials were really up to top standards. They were randomized and double-blind. Okay. Okay, now we have 46 participants. I would like to see you folks give me some more answers. Take a chance. It's a good way to remember. If you don't want to click it in on your clicker, just write it down for yourselves so that you'll know whether or not you got it right. Okay, gonna have to pick one. Okay. Okay. And more of you chose the correct choice than any of the others. And the answer is C. The sample sizes in the 2 trials were different. Remember that the larger the sample size, the more likely you are to find a significant difference if the drug is really good, if there is a difference. Okay. It tells you that they were double blind, so the researchers were not blind, were blind in both trials. It tells you that they were randomized, which does distribute the risk factors evenly. It tells you that the same concentration of vitamin C, it doesn't say anything about different concentrations. And since they were double-blind, a placebo effect would not have happened in one rather than the other. So the answer is that the sample sizes were different. Okay. Try the next one. A study is designed to determine the relationship between emotional stress and ulcers. To do this, the researchers used hospital records of patients diagnosed with peptic ulcer disease and patients diagnosed with other disorders over a 10-year period. The amount of emotional stress each patient was exposed to was determined from these records. This study is best described as, cohort, cross-sectional, case control, or clinical treatment trial. So we're starting out in this research study with people who have peptic ulcer disease and they're already in the hospital, and we're comparing them with people with other disorders, and the risk factor here obviously is emotional stress. Our hypothesis, that emotional stress will lead to ulcers. Or that people with ulcers have a lot of emotional stress. Either way. And the answer is, I know that it's a couple of days later. What do you call a study where we start with sick and well people and we look back into their exposure to a risk factor? What kind of study is that? Okay, my friends, we have kind of a toss-up here. But this is C, a case control study, because we already have cases, this diseased people, and the controls, people with other disorders, and we look at the exposure of both groups to emotional stress. Okay, so that is a case control study. In a cohort study, we might follow people for 10 years. That is, we start now and we go into the future and we look at who develops peptic ulcer disease and who is stressed. Okay, that would be a cohort study. This is a case control study. How are we doing, my friends? Okay. Please tell me if you would like to go over any of these questions or you have any questions on the questions. Okay. A case control study is done to determine if elderly demented patients are more likely to be injured at home than elderly patients who are not demented. The results of the study show an odds ratio of 3. This figure means that if you're an elderly patient who was injured at home, you should be placed in an extended care facility, are 1/3 more likely to be demented, are no more likely to be demented, are 3 times more likely to be demented, and all of these than patients who were injured at home, who was not injured at home, or should be kept at home. What is an odds ratio of 3 mean, my friends? Okay, I see the majority of you are doing very well on this question. Odds ratio of 3 means that if you are an elderly patient who was injured at home, you are 3 times more likely to be demented than a patient who is not injured at home. That is, the risk is 3-fold. Okay, that's what odds ratio is, and that's what relative risk is. But relative risk is done for cohort studies, and this is a case control study. Okay, good. Next question. A study is done to determine the effectiveness of a new antihistamine. To do this, 25 allergic patients are assigned to one of 2 groups, the new drug or a placebo. The patients are then followed over a 6-month period. This study is best described as a, and we have our 4 choices again. What kind of study is this on the new antihistamine? Okay, my friends, you did very well on this one too. This is a little bit of a trick question. This is a clinical treatment trial. That is right, because you are making an intervention. In a cohort study, you would start out with all the people the same at the beginning, but you would wait to see who is exposed to this drug or who is exposed to that risk factor. In a clinical treatment trial, you're giving some people a drug and some people not. Okay, so this is a clinical treatment trial. Okay. Okay, Amani, I'm not sure about which question you're asking about. Okay. So please just give me one or two words in the question that will tell me which question it is. Okay. Okay, an IQ test has high inter-rater reliability. Remember this? This means that the test involves structured interviews, a new assessment strategy is being used. The test actually measures IQ and not educational level. The results are very similar when the test is administered a second time. The results are very similar when the test is administered by a different examiner. What does inter-rater reliability refer to? Okay, my friends, we're almost done. Let's see how we're doing. We're doing pretty well on this one. Okay, this is a terminology. The answer is E. No matter who gives the test, no matter what rater gives the test, you get the same results. If I give the test, if you give the test, we get the same results. That's high inter-rater reliability. Okay, my friends? Good. There are 100,000 people in Hobart, Tasmania. On January 1st, 2012, 50 of these people have disease Y. 50 divided by 100,000 on that date gives which of the following measures for disease Y? Is that point or period prevalence, incidence rate, odds ratio, or relative risk, my friends? Okay, we're doing well. I'd like to see some more of you take some more chances with the clickers. Okay, good, good. Thank you. You extra folks, please come on in. Okay, good, good. Excellent. You guys did great on this question. 71% of you got it right. The answer is point prevalence. This is point prevalence. The number of people who have the disease divided by the total population. Okay, it doesn't tell us that the disease only occurs in certain people. Okay, that's the whole population. Point prevalence. A blood test reveals that a 35-year-old woman at 18 weeks gestation has increased AFP. Of the following measures, which has the greatest influence in determining the predictive value of this test for neural tube defects in the fetus? Okay, predictive value. Okay, that is, with a positive test, how likely is it that the fetus will have a problem? Okay, that is, have neural tube defects. Okay, is it the concentration of AFP, family history of dizygotic twins, prevalence of neural tube defects in the population in question, specificity or sensitivity of the blood test? Okay, so what's most important in determining how predictive this is? Is this right 85% of the time, or is it only right 10% of the time? Okay, what's going to determine that? What's going to affect positive predictive value? That's the question here. What is going to affect positive predictive value? Okay, my friends. Well, this is a hard question. And I'm going to give you a few seconds more for this one. Okay. Three of you only got this one right. The answer is positive predictive value, remember, is influenced by prevalence. Okay? The more common the disease is in the population, the more likely a positive test is going to really indicate real disease. Okay? Sensitivity and specificity do not change. Okay, what we're looking at here is prevalence. Okay, because we're looking at positive predictive value. Remember, positive prevalence does not affect specificity or sensitivity, but it does affect positive predictive value. How are we doing, my friends? Okay. Okay. Remember that when we have a very common disease. Okay, in people with no known risk for TB, a positive reaction to the PPD skin test requires 15 millimeters or more of hard swelling at the site. A group of doctors decide they're going to change the criterion for a positive test in a group of people with no known risk for TB to hard swelling of 10 millimeters or more at the site. So you used to need a great big circle on your arm. This question should be very familiar. But now a much smaller circle is needed to give you a positive test. So with respect to the PPD test, this change in the cutoff point is most likely to increase the sensitivity, decrease the sensitivity, decrease negative predictive value, increase or decrease positive predictive value. Okay, my friends, tell me. Okay. Okay, this change in the cutoff point is most likely to increase sensitivity. Okay, and 89% of you, oh, well, it's a few less. I guess somehow you changed your mind. But 70% of you or so picked the right answer, and that is A. That is, if you make it easier to say somebody has TB, you're going to increase the sensitivity of the test. Okay. However, you will also decrease the specificity of the test. And there'll be a lot of people who are told that they have TB when they don't have it. Okay. Okay, so you will increase the sensitivity. Good. Okay, let's look at the next question. In which of the following illnesses is prevalence rate most likely to exceed incidence rate? Okay, my friends. Let's try this one. This one's not a very hard one. Okay. So prevalence, that is the number of people who have the disease, is much higher than the number of people who got the disease this year. Okay. See if some more folks take a chance. Okay. Good. Okay. Some people are changing their minds. The answer is leprosy. The reason that leprosy prevalence exceeds incidence is that this is an infectious disease that lasts for many years. The other diseases you either recover from, measles, influenza, rubella, or you die from, rabies, okay? In any case, they don't last very long compared to leprosy, which lasts for years. Okay, my friends, how are we doing with that? Okay? Okay, good. Another group of questions. A 35-year-old white male is brought in for an overdose of an illicit drug. After he's stabilized, he details a long list of behavioral and medical symptoms he has experienced due to the drug. They include drowsiness, slurred speech, constipation, and slowed reaction time. The doctor on call observes bradycardia and respiratory depression. Okay. The substance abused by this patient most likely was which of these? A, B, C, or D? Okay. Come on. Some of you, this one is not too bad, I hope. Okay, so let's see you give it a try. Okay. And 70% of you got it right. And this is an opioid. That is correct. This is a drug like heroin, where the patient is drowsy and slow GI tract. That's a hallmark of opiate use. Okay. Bradycardia and respiratory depression as well. Okay. And what are we going to give this patient in the emergency room? Okay. He's overdosed. We're going to give him, what are we going to give him, my friends? I'm going to wait until some of you, beautiful, beautiful. Okay, I guess it's the guys then and the ladies that type really fast that get their answer in first. Okay, good. Very good, but you folks are doing great. That's naloxone. That is correct. Naloxone is used in the emergency treatment of opioid overdose. Okay. Good. And somebody just abbreviated it NX, which is fine. Okay. Okay, a 40-year-old patient is brought to the emergency room by the police after suffering an injury in a car accident. He's been charged with DWI, remember, driving while under the influence of a substance, his third in the past 3 years. He states that he's embarrassed and ashamed and his life is falling apart after 20 years of moderate to heavy drinking. He states he wants to stop drinking and remain abstinent once and for all. What is the safest and potentially most successful treatment for this patient? Okay. You see you have two primary choices here. Most of you are jumping between two choices. Okay. Okay, my friends, let's see how we did on this one. The answer is the best treatment for long-term maintenance of sobriety, as it's called, is Alcoholics Anonymous. Okay, AA. Good. So the answer was D, and we had 45%. Pick D, that is the correct choice. Remember that disulfiram is just an adjunct which is used in some patients, but that the most effective treatment is a peer support group, like AA. Okay, if you have any individual questions, please type them up for me and I will look at the questions. Okay. A 17-year-old male patient is brought to your office because he believes that people on the radio are talking directly to him. When he closes his eyes and listens to music, he conceives brilliantly colored landscapes. He also believes that he can float outside of his body. His hands have a slight tremor, his pupils are dilated, and he's tripping over himself in your office. You suspect that he might have taken which of these drugs? Okay. Okay, so this individual is having delusions, okay, and he's having some kind of mix-up of his senses. That is, he is hearing something and seeing something which is provoked by the hearing something, okay, and that's the kind of thing that we see with hallucinogenic drugs. And the one hallucinogenic drug that is most likely to have caused these is, in this case, mescaline. Okay, mescaline is used in some religious ceremonies. It is a hallucinogenic drug. Okay, so the answer was C, mescaline, and 35% of you got that right. Okay. A male is confronted by the police after randomly and viciously attacking an innocent bystander who he thought was following him. He begins screaming obscenities at police officers. He's also exhibiting involuntary eye movements. When he's being handcuffed by the police, he begins to fight again. He is clubbed several times but seems to feel no pain. He has probably taken which of these drugs? Okay, timer. Okay. Okay, which drug has he taken? Okay. We don't have the timer, so I'm going to guess when 30 seconds is up. Okay. He has probably taken, very nice, 50, the numbers are still changing, so let me wait a second. Okay, 55% of you picked PCP, which is the correct answer here. Remember, with PCP, we have the nystagmus, the abnormal eye movements. And we also have aggression and violence. So he is psychotic. He is paranoid. He thinks somebody's following him who is not. The eye movements and the aggressiveness all indicate PCP. With LSD, the patient would not be aggressive, okay, and would not have the eye movements, not with any of the others either, okay? With the inhalant, he might be aggressive, but he doesn't have the eye movements. Okay, good. Can board questions, Shireen is asking, can board questions be direct like this one? You are right, Shireen. They are very rarely as direct as, I think you may be referring to this one or this one. They will be much longer, okay? But the same information will be in them. They may even give you more information, which will make it easier for you to distinguish which drug it is, okay? And typically you can answer the board questions without looking at the answers. That is, you should be able to answer the question without looking at the answers. So if you don't see the answers on this question, you have to guess he's been taking PCP. The answers should not be long and require you a long time to go through them. Okay. I cannot see that. I barely can see it. Okay. Okay, well, we can answer this one. Which of the following medications is most likely to have the side effect of causing priapism, persistent erection? Okay, my friends, give that one a try. Oh, I like what I'm seeing here too. Very, very nice. Very, very nice. This is trazodone. Okay, trazodone is the one that's most likely to cause priapism. Good. Okay. I'm just making a note to take that extra underlining out. Okay. The sexually transmitted disease with the highest number of new cases is which of these sexually transmitted diseases? Okay. Well, we have some more people jumping in on this one. Okay, good, good. Okay. Now, if I had you in front of me, I'd be calling on you. Especially if you didn't look me right in the eye. Everybody who looks down gets called on. People in the front row get called on. Okay. And people in the far back row also get called on. Okay. Okay, my friends, but I can't call on you, so I'm going to have to hope that you will click in your answer. Okay, and the answer is, and 50% of you got it right, chlamydia. Okay, chlamydia is the sexually transmitted diseases with the most new cases. Okay. A urologist is arrested by the transit police after being caught filming under unsuspecting women's skirts while sitting across from them or standing under the stairs using a camera pen attached inside a newspaper. When questioned by the police, it's discovered he's been doing this several times a week. He's married with children and has recently been named Physician of the Year. Which paraphilia does the doctor have? So what we're dealing with here is somebody who's really a paragon of the community, who's showing an illegal behavior. And what illegal behavior is this? Okay. Okay, so these are some of the sexual paraphilias. Question is, which one best describes this man's behavior? And about 50% of you about got it right. And this is voyeurism. This is somebody who is observing people in a sexual way when they do not know he's observing them. Okay. And it is illegal. And he's going to have a lot to explain. Okay. And he may go to jail for that. One of the things that's often offered to people with paraphilias who have hypersexual kinds of behavior like this would be to take an SSRI, because that does decrease sexual interest, or to take an anti. Okay. E is correct. Absolutely right. The 9 of you that got it right, and that was more than anybody chose any of the others. This is demonstrating a fetish. This is a transvestic fetishist. Okay. It's a heterosexual man. So he's not transgender. He doesn't feel like he's in the wrong body. He's not transsexual, which is very similar to transgender. He's not homosexual or bisexual. He has a special need, a fetish. Okay. Okay. A very concerned mother of an 11-year-old boy brings her son to the office after discovering him in bed and fondling touching inappropriately his 4-year-old cousin. She also reports that the teacher has noticed his grades slacking, going down, and his behavior is unsociable with the other kids for the past 3 months. What should you consider as a possible cause of the patient's behavior? What is the most likely cause of the patient's behavior? And we did talk about this in a somewhat different context. Beautiful. Okay. Very nice. Very nice, my friends. Yes, this is child sexual abuse. This 11-year-old child has been abused by an adult, most probably. Okay. This is not normal behavior because the children are of very different ages. Okay. Oh, concerned parents tell the doctor that last week their daughter walked in on them while they were having intercourse. This is a question that has been on the last few board exams, very, very close to this. Last week they found their daughter with another 6-year-old girl playing the male role in what looked like a simulation of sexual intercourse. This physical exam is normal. The next step for the doctor to take is to reassure the parents that this behavior is normal for children of this age. Tell them that the child is likely to have a lesbian sexual orientation. Refer the family to a child psychiatrist. Evaluate the child's sex hormone levels, or advise the parents that the child has probably been sexually abused. Okay. 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 Good. I like what I'm seeing. I like what I'm seeing. And the answer is very nice. The answer is A. Yes, this is normal behavior. Reassure the parents that this behavior is normal. The children are both the same age. It doesn't matter if they're boys or girls or a boy and a girl. This is normal behavior. And nothing will happen to the child when she grows up because she has observed the parents. This is normal behavior. It does happen. We advise the parents to put a better lock on their bedroom door. Okay. Okay. Question, transsexual equal transgender. Yes, they are the same thing. Okay, transgender, transsexual. And the correct term in the DSM-5 is gender dysphoria. And this individual did not have gender dysphoria. Okay. Okay, so this practicing behavior, 2 kids of the same age, is normal. Okay, a woman and her 15-year-old daughter come to the doctor's office together. The mother asks the doctor to evaluate the daughter for a birth control device. The most appropriate action for the physician to take at this time is, and again, this is one that may have some cultural differences, as you can see. How are you going to answer this on the USMLE? Do you follow the mother's wishes, ask the mother why she wants the device, recommend that the girl see a counselor, ask to speak to the girl alone, or ask the girl if she is sexually active? Okay. Okay. Okay, good. Very nice. Okay. And I like what I'm seeing here too. Very, very nice. The answer is D. Speak to the girl alone. Okay? She is not going to tell you anything with her mother in the room. Okay? And when you do have her alone, then you'll ask her if she's sexually active, but not until you're speaking to her alone. Okay? So D is the correct answer, and 83% of you got it right. A 50-year-old diabetic patient states that he and his wife are having problems in bed. The most appropriate next statement for the doctor to make is, sexual problems are common in diabetes. Please tell me what kind of problems you're having. I can recommend a sex therapist with special expertise in diabetes. Patients with well-controlled diabetes have fewer sexual problems. There are forms of sexual expression which do not involve sexual intercourse. And the answer is okay, very nice. We're just about, and the answer, in fact, 70, whoops, it just dropped down. 68% of you got it right. That is, tell me more. Tell me what kind of problems you're having. Before you make any recommendations or you tell the patient anything more, let's talk about what's going on, because he hasn't told you what the sexual problem is. Okay. And in diabetes, of course, you know it is typically erectile dysfunction. Even though orgasm may be normal, erectile dysfunction is the problem. So you've got to know that before you can make any recommendations. Okay, so tell me more. Okay, a 20-year-old college student who has been cramming for exams for the past 4 weeks comes into the ER with rapid heart rate, sweating, and shaking. The students note that he has been drinking 8 cups of espresso coffee per day to stay awake during exams. The most likely diagnosis is, okay, my friends, how about this one? Okay. Okay. What is this? Right, this is a category of under substance abuse. It is substance abuse anxiety disorder. That is, the coffee is making him shake like this. So of course our recommendation would be stop drinking all that espresso, or at least cut back on it. Okay. If he stops altogether, he's going to be very, very sleepy and very, very hungry. Okay, and he may even be a little depressed. So we would tell him cut back every day, cut back on 1 or 2 cups until you're drinking just 1 cup a day or no cups a day. Okay, good. A 19-year-old girl who has been at a party is brought to the emergency room after having a seizure. Her blood is positive for diazepam, cocaine, and marijuana. Which of the following is most likely to have caused the seizure in this patient? So we only have 5 choices. So if F is the answer, if any of these questions have more than 5 choices, pick E, and that will include E and whatever else is after it. Okay. So what's the answer to this question? Seizures. She has diazepam, cocaine, and marijuana in her system. So this is an overdose rather than withdrawal because she's got all the drugs in her. Okay, so what is this? Okay, good. Still see the numbers changing, so I'm going to wait until all of you respond, or most of you respond. Okay. And in fact, yes, the answer is cocaine, overdose of cocaine, or just using cocaine. Okay, so cocaine increases dopamine. Dopamine promotes seizures. Okay, diazepam would reduce seizures. Marijuana would not cause seizures. Now, withdrawal of diazepam could cause seizures as well, but they're telling you that this girl was at a party. Okay, so she's unlikely to be withdrawing from any drug. She's more likely to have used the drug. Okay, so that would be the overdose of cocaine. Good. Okay, we're going to do a couple more questions, then we're going to take a break. A 40-year-old female patient is brought in by ambulance. The woman initially shows clenched fists. Okay, I'm going to make a note to correct that. Clenched fists, intense tooth grinding, and shortly thereafter begins to experience violent seizures. Her colleague states that over the last 6 months, the woman has frequently been late for work and has been given warnings because of irregularities in her work. The friend also states that the woman's mother died yesterday, and the patient has been with her mother 24 hours a day for the past 3 days. Of the following, what is the most likely cause of the patient's seizures? Okay. Okay, my friends, how are we? What's causing this patient's seizures? Okay, countdown. I'm going to watch the numbers to see if any more of you are answering. Okay. And I'll give you some more time to answer the question. Okay, I think that's it. Some of you are still switching around. Okay. My friends who chose alcohol withdrawal have the right answer. Now, the reason that this is alcohol withdrawal is, first of all, the fact that she's been having problems at work and she's having irregularities, so she's using alcohol. Okay, she could be using, though, another drug. The woman has been in the hospital with her mother for 3 days while the mother was dying, unfortunately. So for 3 days, she hasn't drank any alcohol. So the seizures, the tooth grinding, indicate alcohol withdrawal. Okay, if alcohol withdrawal is a choice, pick it. Okay, this picture is a classic picture of delirium tremens. Okay. Okay, so alcohol withdrawal. Okay, my friends, good. Not a seizure disorder. This is not factitious disorder. The woman is not faking. She would have no reason to fake. She's having seizures, real seizures. Okay, and she's not faking. There would be no reason for her to do that. Okay, so this is alcohol withdrawal delirium, delirium tremens. Okay. Okay, I think what we'll do now is take our last break of the morning. Okay, my friends? So let us take a 10-minute break. Okay, my friends, welcome to our last hour together. Okay. And this question, and I need my pointer. Oh, it's hiding all the way up here. Okay, thank you. The husband of a woman who gave birth to a healthy infant 2 weeks ago reports that he found her shaking the infant to stop it from crying. When the doctor questions the woman, she says, "I did not realize it would be so much work." The patient also reports that she wakes up at 5 a.m. every day and cannot fall back asleep and has very little appetite. The next step in management is for the doctor to assess the patient for thoughts of suicide, advise the father to hire a caregiver, set up another appointment for the following week, prescribe an antidepressant, or tell the father that the mother is showing evidence of the baby blues. Okay, my friends. And timer. Okay. Okay, I'd like more of you to check in with us here and answer this question. I'm going to watch and see if numbers keep going up. I'm going to let you have a little more time. Okay, you're having difficulty with this question. This patient is showing evidence of depression. That is, she wakes up early every day, she can't fall asleep, she has very little appetite. She's also showing some really abnormal behavior, that is shaking the infant. Okay. Okay, so what are we going to do now? the most important thing to do when a patient is showing signs of depression is, and the answer is A, assess for thoughts of suicide. Okay. You always want to find out if she is a danger to herself as well as a danger to the infant. You're going to also ask her questions about harming the infant. Okay. So the answer here is A. Okay, my friends. Okay, a doctor asks a diabetic patient, "Do you have any other questions?" The patient is embarrassed and says he and his wife are having problems in bed. The doctor should say, what? Okay, this is kind of a sketchy question. Okay, don't worry, it's common in diabetes. Okay, what kind of problems? I'll refer you to a sex therapist. The answer is, my friends, okay. I'm pleased with this one. Okay. Okay, very nice. We got lots of responses on this one. Okay. And this question, the answer is what kind of problems? And 100% of you got it right. I applaud you. Applaud yourselves. Okay, very nice. What kind of problems? That's right. You don't say this is common in diabetes. You see what you can do to help the patient. You want to know what the problems are. We had a similar question. A 78-year-old man who needs pain medication tells the doctor that he doesn't want to take it because he's afraid of addiction. The doctor should say, pain patients have little chance of addiction. Try to take as little medication as possible. So do not take the medication. Tell me why you're afraid of addiction. And the answer is a timer. Okay. Okay. I know how many of you can click in now. Okay. Because of the question where everybody got it right. Okay. Okay, my friends. And the answer is, tell me why you're afraid of addiction. That is, let's talk about the problem. Okay? And pain patients do have a small chance of addiction, but they do have a chance of addiction. Okay? And we want the patient to take his medication to relieve his pain because we know that pain patients who take their medication, and in general, people who have less pain have better recovery. Okay? So patients who are experiencing pain have stress and do not recover as quickly or as well. Okay, good. An 81-year-old man asked for a testosterone patch for occasional sexual dysfunction. The doctor should start the counter, prescribe the patch, prescribe Viagra, give him a physical and measure his testosterone levels. Tell him that erectile dysfunction is normal at his age. Okay, my friends, how are we doing here? Good? Good? Okay. Yes, and the answer is C. You want to physically evaluate the patient, and before you give him testosterone, you have to measure his testosterone levels to find out if they are within the normal range. Okay? We don't dismiss him. We treat him aggressively. But first we have to totally evaluate him. Okay, very good. We also have to give patients who ask for Viagra physical, certainly. Viagra has a lot of cardiovascular effects, and the patient has to be carefully evaluated before we give them a prescription. Okay, for anything. Okay. A patient is brought to the emergency room after having a cooking accident in which he practically severed his finger while carving a turkey. While you're attending to his injury, he goes into a long discourse on the probabilities and statistics of your saving and reattaching his finger. statistics on the number of kitchen accidents that happen during the Thanksgiving season. This discourse is an example of the use of what defense mechanism, my friends? Okay. What defense mechanism is this patient using? Okay. Well, most of you got this one right. This is intellectualization. He's doing all the statistics and all of these things to avoid really thinking about the significance of what he's done. This was quite a bad accident, okay? So he is using intellectualization to avoid emotion. A 17-year-old boy goes into a rage in the emergency room. He completely destroys the exam room, throwing chairs and smashing windows. When he calms down out of sheer exhaustion, he tells you that his mother abandoned him and left town the day before with her boyfriend, but that he doesn't care. This patient's temper tantrum is most likely an example of, and is it displacement, undoing, isolation of affect, acting out, or intellectualization? This question is a little bit hard. Okay. Okay. I'll give you a few more seconds. We have to go a little bit faster so that we can get through the questions. Okay. Okay, my friends. How are we doing? Good. Okay. And this is, in fact, acting out. So 62% of you got it right. He is acting out. He's throwing himself around, breaking things, because he cannot really deal with his mother's leaving him. And he does really care. Okay. What if he was told by his mother that she was leaving because he is a piece of junk? He now screams out his mother's name each time he smashes an object or furniture. Okay. What is this? Okay. My friends are good on defense mechanisms. Okay. All right. Let's have some more clicking in. All right. Okay. Very, very nice. The answer is displacement. And about 80% of you got that right. He's very angry at his mother, and he's smashing furniture as a direct result of his anger at his mother. He's displacing his anger onto the furniture, but she's not there, and he can't get angry at her. My mother left me, and I am really upset about this, he says, in the most bland and matter-of-fact tone. What defense mechanism is he using? And this is one that we didn't really talk about. If we did, it was very little that we talked about it. Okay. That's not stopping you guys. You guys are doing good. So he says, I'm really upset about my mother leaving him, but there's no emotion expressed in his face. Okay. Okay, this is very nice. Isolation of affect. He does not appear to be experiencing any emotion associated with this, although he feels very emotional. Okay. Isolation of affect. My mother left me because she had to find herself. She had to live her life, pursue her dreams, and may even have been having some hormonal changes. So maybe that's why she did it. Okay, my friends, what do you think about this one? So he says, well, maybe that's why she did this terrible thing. Okay. Okay, very good. This is D, rationalization. That is, he's making up a reasonable explanation for her leaving him. Okay. What if his mother beat him severely before she left? He's brought into the emergency room, and you ask him why she did this, and he says, what are you talking about? My mother never touched me or left me. Defense mechanism. friends. Yes, yes, my friends, right. This is denial. It didn't happen. She didn't hit me. She didn't leave me. He is in denial. Okay, good. What if she left him and he says to you, I know she left, but she is an angel and he is the devil. Her boyfriend made her leave. Defense mechanism. He's this, he's a devil, she's an angel. It's all his fault. Okay. Yes, my friends, 61% of you got it right. It is splitting as a defense mechanism. He's a devil, she's an angel. He cannot see her culpability, the fact that she is responsible as well as the boyfriend. He has to see the boyfriend as totally bad and the mother as totally good. Okay. Splitting defense mechanism. Okay, let me just check this. Okay. I can't remember where. Well, he should remember this. I mean, after all, she told him where she was going, but he can't remember it. Okay. Very good, my friends. Yes, this is blocking as a defense mechanism. He cannot remember where she's going because he's so uncomfortable remembering it that he has pushed it into his unconscious mind. And every time he tries to remember it, he can't do it. Okay? He can't remember it because it makes him uncomfortable. That memory is something that he doesn't want to have. Okay? Unconsciously. Blocking is the answer. An 18-year-old woman that you've been treating for many medical issues now presents with severe headaches and nightmares related to repressed memories of sexual abuse by her father. As a doctor, you want to gain better insight into her conscious and unconscious issues. This patient should be referred for testing in order to be administered. Which one of these tests is associated with getting the unconscious basically into consciousness or investigating the unconscious mind? Okay, my friends, what do you think? This is a tough one. Okay. But you guys are definitely nailing it. Okay. You're nailing it. Good. The answer is the TAT. Remember the thematic apperception test where we had a picture of two individuals? They may have been women, they may have been men, one behind the other, a young one and an old one. And when we find out what's going on in this picture, we get an idea of what's going on in your unconscious mind. Okay. The other tests are neuropsychological tests or IQ tests, and they are not related to unconscious issues. Okay? Okay, now some of you are asking, is the classification for the defense mechanisms important? And I haven't talked about it because it is not important. You don't have to know which ones are immature. Okay? Okay, so it's not relevant. Remember, I'm only covering the stuff that you really need to know for the USMLE. Okay. Okay, how about this one? We have, the judge asks you to evaluate and determine whether a defendant is legally insane. Knowing that you're testimony will be given the highest scrutiny. You determine that your regular protocol must now be bolstered by an objective personality test. Therefore, you decide to administer which of these tests is an objective personality test. That is, it can be scored by a machine and doesn't require a clinical psychologist to interpret it. Tantrums is to give him a swift smack on the behind, okay, place him in an age-appropriate timeout, explain the concept of family time versus personal time. Do you think a 3-year-old is going to understand that? Well, you can try. Get him to understand how it must feel for other people to give up their show. He's a 3-year-old, remember. Let him watch his cartoon, then discipline him later when he is calmer. Okay, my friends, what do you think? Okay, what do we think here? Okay, my friends. B is the answer. Timeout is the best recommendation for disciplining this kid. Okay, so when he starts screaming, you ignore him. You tell him he has to sit in a certain place in the room, maybe in his chair or on the floor. But you don't pay any attention to the screaming. Okay, and you certainly don't do what he wants you to do. Okay. B is correct. A mother brings her 8-month-old to the pediatric office. He cries whenever anyone other than a close family member or nanny walks into the room. The mother noticed that he cries when a non-family member walks in the room, even though the mother is holding him in her arms and trying to comfort him. Now she's afraid he might have anxiety disorder or even a social phobia. Your best medical practice is to, okay, observation to rule out a more serious problem, psychological testing for this little 8-month-old, systematic desensitization or implosion. Okay. Tell her to keep him away from anyone outside the family. Okay. For a few months. Or tell her that this is normal behavior and should disappear by his 2nd birthday. Okay. And the answer is, in fact, E. What this child is showing is normal stranger anxiety. Okay? So it's not separation anxiety. This is stranger anxiety. He's afraid of people who are unfamiliar, and he's just at the right age for that. That is, he's 8 months old. He can recognize who the familiar people in his life are. So the answer is E. Tell the mother this is normal behavior. In a very tragic case, you determine that a 4-year-old has inoperable brain cancer and doesn't have long to live. You tell her the bad news to the child in the presence of her parents. They have the right to refuse to tell her, by the way. It's up to the parents to decide whether or not the child will be told. To your amazement, the little girl accepts the news quietly and tells you after she goes to heaven, she will resume her life with her family and friends. What is the most likely explanation for the child's reaction? Start the counter. Belief in the afterlife, belief in reincarnation, that a person is reborn into a different form, perhaps a different person or an animal. Denial, she has no concept of death as an irreversible process. Or brief psychotic disorder. What is the best explanation for this? Okay. And the answer is, and you guys have gotten it, D, that she has no concept of death as an irreversible process because she's too young. It's not until 6 or 7, or even a little bit older, that a child understands that death is permanent, but at least 6 years old. Okay. Sleep spindles and K complex are seen in the waves of which type of sleep? Now, this is a really short and easy question. You can be pretty sure you won't see anything this short and easy on the boards. Let's try it. Okay, my friends. Okay. Sleep spindles and K complexes, combinations of what came before and what will come after, are seen in stage 2 sleep. Okay. Unfortunately, only 30% of you got it right. We will see the very tightly packed waves only in REM. We're not going to see K complexes. K complexes are those tall waves that look like delta waves. That's in stage 2. Okay. A medical student has collapsed in the anatomy class. A friend has witnessed these incidents and states that he sees a sudden dropping of the head and a complete collapse onto the floor. The patient's speech becomes slurred and his sight impaired. However, hearing and awareness remain undisturbed. He also complains of being very tired every day. You now suspect a sleep disorder. What medication would be most helpful for this patient? Okay, so he is collapsing while he is still awake. Okay. What is this? What it is narcolepsy. Okay. And what, right, Esron, very good. And what is the right treatment for narcolepsy? Okay. What's the right treatment for narcolepsy of these 4 choices? Okay, Ezra, what do you think the right choice is here? You got the disease first. What do you think the best choice in management is? Okay. Okay, I hope you clicked in with the right answer, and the answer is modafinil. And 50% of you got that one right. Okay, now temazepam and flurazepam and triazolam are all benzodiazepines. You don't use benzodiazepines for narcolepsy. You'll put this person to sleep all day long. Okay. Plus, these are the hypnotic benzodiazepines. So the stimulant, modafinil, is the one that you use. Okay, my friends. A patient complains that although she's in good health and she exercises, an 82-year-old has problems with sleep. Okay, she doesn't have the deep delta sleep that she once enjoyed. Dreams less. She has less REM sleep also. She sleeps less soundly than ever before. She doesn't drink or take alcohol. She doesn't take alcohol or caffeine. Doesn't snore. Doesn't have any health problems aside from minor changes. Her mental status and function are normal. The best medical advice to handle this issue is you have an irregular sleep phase disorder, you have sleep apnea, you have sleep problems that are typical in aging, you may have early signs of depression, or let me write you a prescription for a sleep aid. And the answer is very nice, my friends. These are sleep problems that are typical in aging. That is, the patient has less delta sleep, less REM sleep, okay, and she sleeps less deeply than she did before. Okay, so she just has typical problems with sleep associated with aging. Okay. Okay. This is, now we're getting into the psychopathology, a couple of psychopathology questions. Here we have a bizarre guy. He's wearing a top hat, a tuxedo, and flip-flops. He's never had close friends. He often thinks that others are trying to take advantage of him. He's always known that he's superior to the human race because of his superhuman energy, off-the-chart intelligence, and the ability to read other people's facial expressions. What is the provisional diagnosis that you would give this patient? Here's a tough question. He's not actually showing frank psychotic symptoms, but he is very, very strange. Okay. He's a little bit paranoid. He's dressed very strangely. Okay. So what is this, my friends? Oh, you are doing beautifully on this one. Very, very nice. Yes, in fact, this is a personality disorder. It looks a little bit like the schizotypal personality disorder. Okay. It's not clear completely which one it is, but this is a personality disorder. Not schizophrenia. Okay. He's not showing any frank hearing voices or seeing things that don't exist. Here we have a woman who comes to see you at the urging of her husband. She's respecting the husband's wishes. She has had some issues in the past 2 years. She doesn't think, though, that she needs psychiatric help. She does admit to having a pattern of ups and downs that appear in almost equal numbers. There are times when she feels a great amount of energy, feels on top of the world, and has enough libido to make her husband scream, "Uncle." Uncle means I give up. Okay. However, 3 or 4 days later, she wakes up feeling exhausted and sometimes depressed. However, she always powers through, makes it to work every single day, and takes care of her 3 children. What is the most likely diagnosis? Okay, my friends, how are we doing with this one? Okay. Okay. And this is, my friends, cyclothymia or cyclothymic disorder. She does not have mania. She feels great. She has an increased libido, but she doesn't have any impairment in her functioning. She works every day. She takes care of all her children. She also sometimes has dysthymia. Okay? People with bipolar disorder, when they are manic or depressed, cannot power through. They cannot work. They cannot take care of themselves or go to work. Okay? So this is a milder form, and this is cyclothymic disorder. And they also have in here, for 2 years, she's been this way, which is the requirement for cyclothymic disorder. Okay. Okay. A woman has joined an online chronic illness support group. This is a new board question, claiming that she's fighting stomach cancer. Subsequently, she gets an outpouring of emotional support from her internet group. Soon enough, it's discovered that she has joined another online support group, okay, claiming to have inoperable lung cancer. Or rather, brain cancer, not stomach cancer. When confronted by the 2 groups, she breaks down, cries, apologizes, and says she doesn't know why she makes up these stories. She then quits both groups. However, a month later, she joins another support group with another chronic made-up illness. This woman is showing evidence of what? Okay, what do you think? Okay. This woman knows that she's making up the stories, but she doesn't know why she's doing it. She doesn't know why she does this. Okay. So this is, and 55% of you got it right, factitious disorder. That's right. This is factitious disorder. She needs to be considered a sick person, but she doesn't know why she needs to be a sick person. And this is a very strange kind of behavior, that a person would join a support group of very sick people just so that they can be considered a sick person. That is a good example of factitious disorder. Okay, good. A man is brought to a New York hospital by police in a disheveled state. He was mugged and beaten up in a homeless shelter. He says that he's upset and confused. Further questioning, he can remember his name, but he can't remember whether he has a family. He says he just feels lost. He doesn't know what he's been doing for the past 2 weeks. The policeman discovers that he was declared missing by his wife and family in California 2 weeks ago. Okay. Now we have to say with this person that this individual there are no medical findings. Okay, no medical findings. Okay, what's the answer here? Okay, my friends. Okay, yes, this is dissociative amnesia with fugue. Okay. Now, it will have to say, though, because he was mugged and beaten, we have to rule out neurological damage. Okay, but they don't give you one of those choices here anyway. Okay. Somehow it also, okay. It has to say in this question that there are no medical findings. Okay. And he's found in a different place from the place that he left. So this would be dissociative amnesia with fugue. Okay. Good. Motor and vocal tics associated with Tourette's are most often treated with which one of these drugs? Which one of these groups of drugs? This is a good question because it doesn't ask you specifically. It just asks you, what do you treat this syndrome with? Okay. And the answer is the antipsychotics. Remember haloperidol and pimozide? This is treated with antipsychotics. Okay. Very good. Which of these medications is most likely to slow the progression of Alzheimer's disease? Okay. Very, very nice. And the answer is an acetylcholinesterase inhibitor. Okay. If they had an NMDA receptor antagonist, that would be the right answer also. Neither one is better than the other, so they won't put them in the same question. Okay. A patient tells you he's on antidepressants, but he stopped taking them before because he experienced sexual side effects and weight gain. He would like to try antidepressants again, but he cannot live with those two side effects because of their impact on his social functioning. What is the best medication to prescribe from this group for this man who was gaining weight and had sexual problems with the drugs that he had been taking? So which is the best one, the one least likely to cause those problems? Okay. Okay. I'm checking to see who's clicking in here. What are you going to recommend for this guy with depression? We need an antidepressant that is less likely to cause sexual side effects. Very nice, my friends. The answer is bupropion. Correct. That is the only one that has no serotonergic action, that actually has some dopamine increasing action. Okay, so most of you did get that one right as well. A patient who with a history of care for depression is now in her first trimester of pregnancy. She's severely depressed and has a history of suicidal gestures. And now she's saying she wants to commit suicide. If she has to receive psychiatric care, which poses the least risk to her and her baby, but also has a significant and quicker effect on the depression, what will we use for this pregnant woman with an extremely severe depression with suicidality? Okay, I like what I see here also. I like what I see here. Yes, the answer is electroconvulsive therapy because it works really, really fast. Okay. Okay, here we have a patient who's on the move. She's often elated. She's grandiose to the point of being delusional. Grandiose means she thinks she's fabulous. She can jump off a roof. So we know that this patient has bipolar disorder because we see a manic episode. But quickly, very quickly later, she has a total lack of energy. She's helpless and hopeless. She goes into a depression. A day later, she snaps back into a manic phase. At least 4 times in the past year. Remember, this is rapid cycling bipolar disorder. What is the best choice of treatment? And this was a small fact that we went over. Let's just see if any of you have the answer to this. Okay. The best choice of treatment for the rapid cycling bipolar disorder is... Okay. Okay, my friends, give it a try. Okay. The answer is valproic acid. That's right. That's the one that's used for the rapid cyclers. Lithium is used for the standard kinds of bipolar disorder, not somebody who snaps back and forth from one mood state to the other. This is valproic acid. Okay. Good. You shouldn't have 2 underlines there. Okay. Okay, here we have a patient who's at the Federal Correctional Institution in Virginia. He's agitated, paranoid, delusional, auditory and visual hallucinations. He's not compliant. He is incompetent, needs involuntary medication. What medication would you prescribe, keeping in mind the need for compliance and administration of the medication only once every 2 to 3 weeks? So which drug are we going to give this patient who can only take the drug once every 2 to 3 weeks? Most of the drugs, and 3 out of the 4 of these drugs, have to be taken every day. One of them can be taken every few weeks. Okay, my friends. And the answer is, beautiful, 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 fluphenazine decanoate. Remember, that is the long-acting, injectable, slow-release formulation of an antipsychotic. Good. And this is our last question, my friends. So we have a patient who's been having anxiety and depression for his whole life. He was placed on antidepressants before, but he can't tell you their name. However, when he was placed on that drug, he had nausea, vomiting, chest pain, elevated blood pressure, stiff neck, when he consumed certain foods and beverages with his medication. So what medication should we prescribe now to treat his anxiety and depression? Okay, my friends, this whole picture, remember we talked about this, this is the hypertensive crisis, which means that he was taking an MAO inhibitor. So which of these medications is not an MAO inhibitor, my friends? Which is not an MAO inhibitor? Give you a few seconds to get this. Okay, which is not an MAO inhibitor. Remember, you do need to know the names of the drugs and what group they fit into, whether they're MAO inhibitors or cyclics or, okay. Okay, I like what I'm seeing. I like what I'm seeing. Okay. The one drug here that is not an MAO inhibitor is venlafaxine, which is, as you know, an SNRI. Okay, and that would have no food interactions. Phenelzine, isocarboxacid, and selegiline are all MAO inhibitors, and we stay away from them in a patient who's had a reaction to them before. Okay, my friends, we are finished. Our time together is over. I want to wish you all the best of luck on USMLE. Okay, and I hope I see some of you again for Step 2 review. Good afternoon and have a great evening.